actual to engage in conversations that have the power to shape the world we live in. It is here, within these walls, that the seeds of ideas are sown, nurtured, and allowed to flourish into remarkable achievements. The energy and excitement in the air are palpable, and we embark on a journey of exploration, knowledge, exchange, and the forging the lifelong connections. This conference is a testament of the collective power of human potential. Our presence here signifies our commitment to growth and our unwavering belief in the transformative power of ideas. Each one of you brings a unique perspective, expertise, and experience that will enrich the discussion and fuel the fires of progress. Together, we can unlock new frontiers, challenge conventional wisdom, and inspire one another to achieve greatness. Throughout this conference, we will engage in rewriting keynote speeches and presentations. We will witness the birth of new collaborations, the sharing of profound insights, and the fostering of friendships that transcend borders. Each interaction holds the potential to be a turning point in our personal and professional lives, propelling us forward on the path of excellence. Let us seize this opportunity with open hearts and open minds. Let us embrace diversity, respect differing viewpoints, and engaging in constructive dialogue. In doing so, we can harness the true power of unity as we work towards solving the grand challenges of our time and shaping a brighter future for generations to come. On behalf of the organizing committee, I extend my deepest gratitude to our Honorable Advisor Sir, Mr. Vedant Gagji, Registrar Ma'am Dr. Hima Bafila, President in Charge Professor Dr. Raghav, Dr. Dharmendra Ahuja, Dean Faculty of Pharmaceutical Sciences, and to all the speakers, staff members, and to all my dear JVNs who have dedicated countless hours to make this conference a reality. Without your unwavering support, none of this would be possible. May this conference be a source of inspiration, enlightenment, and profound connections. May it ignite the flames of creativity within us and leave an indelible mark on our journeys. Together, let us make the new next few days as unforgettable experience full of wonder, discovery, and endless possibilities. Once again, welcome to this 2 days virtual international conference on emerging trends in pharmacotherapy and health technology. Let us embark on this extraordinary adventure together. Thank you. On behalf of Faculty of Physiotherapy and Diagnostics and Faculty of Pharmaceutical Sciences, I first welcome our first speaker from Indonesia, Dr. Yudit Sandhya. He's working in Indonesia as a medical physicist. So I warm welcome you, sir. You can continue.
Thank you, Dr. Ankit. Okay, let me present my presentations. Okay, sir. Can you see my presentations here?
Yes, we can see.
Okay. Good morning, all the participants. I'm so happy to involve in this international conference. So let me introduce myself first. My name is Yudit Sandhya. I'm a medical doctor, rehab doctor especially since 2014. This morning, I'll try to do a presentation about the shockwave therapy for pain management. First, I have to disclaimer first that this presentation is for educational purposes. The techniques on the treatment is contributed from EMS Dollar Class Academy. So the shockwave therapy is a non-invasive treatment for musculoskeletal using a single acoustic pressure pulse, characterized by a rapid rise to high peak pressures. And the idea is to provide tissues with stimulus generating to repair sequences. So for the general extracorporeal shockwave therapy, there are two types of shockwave therapy. There are radial extracorporeal shockwave therapy and the focused extracorporeal shockwave therapy. The difference between these two is on the therapy area, radial is over the larger area than the focus one, and the pulse durations and the penetrations of the tissue is more deepest in the focus extracorporeal shockwave therapy. I might say that radial shockwave is more superficial than the focus one, but on the other hand, the focus one could make a tissue damage if the therapy is done repeatedly. So, as you all can see in this picture, there is a compressed air that deliver from the air compressors and accelerate the projectile, then makes a cavitation through the applicator. And as for the radial shock wave, the penetrations is up to 4 centimeter deep into the body, and the shock waves are believed to exert physical forces in tissues in two ways. First, there is mechanical stress from exposure to the high peak pressure shock waves. Second, in liquids, shock waves form a cavitation bubbles. As you can see, this is the cavitation bubbles, which are focal areas of vaporization of the liquid. These cavities then collapse when subjected to high pressures, resulting in a local trauma and neovascularizations. And the mechanism of actions of the extracorporeal shockwave therapy, there are four mechanisms of actions. First, that it can saturate the C nerve fibers, so it can reduce the pain. Pain transmission is blocked, and the neurogenic inflammation is stopped. And then number two is the increase the blood flow or neovascularization to bring the oxygen to muscles and then make neovascularizations growth. And then the number three is activate the mesenchymal stem cells, such as osteoblasts, and enable tissues and bone reconstructions. And the fourth is release the growth factors. There are so many indications for using the shockwave treatments, but most of it for musculoskeletal disorder. There are some studies ongoing for the neuromuscular problem, such as the carpal tunnel syndromes, or the piriformis syndromes, or the spasticity in stroke patients and cerebral palsy. But on my clinical practice, I have found it useful on those two cases, the carpal tunnels and the piriformis syndromes, and the pain or the tingling sensations have
फिजियोथेरेपी डिपार्टमेंट किस तरफ होगा
reduce it significantly.
सीधे
And then for the contraindications, the
नहीं
following is
डिपार्टमेंट
the
जहाँ
air
पढ़ाई होती है वहां जाना
filtration.
ओपीडी में नहीं जाना
You cannot do it on the lungs or the guts of the patients or the client. And then for the pregnant woman, you can use it in another body, but not on the belly of the patients. For the local tumors or cancer, you have to make sure that the cancer is not growth rapidly if you apply the shockwave therapy. And then for the local cortisone injection, it might say that if the area was injecting by the cortisone, it makes the tendons can be ruptured if you apply the shockwave therapy. And then for blooding disorders, you cannot do the shockwave therapy on the blooding disorders because it can make the blood or the bleeding is never stopped. And then the patients under the age of 18, because they have no concern about the therapy, and then the pre-rupture tendons. This is how you generally do the shockwave treatment. You can do it on the painful area or the other area that affect the disorder. In this case, for the plantar fasciitis problem, you can do it on the painful area, which is on the heel, and then you mark. But you can do it the shockwave therapy on the other area, such as the gastrocnemius muscles or the Achilles tendon. Because if you see or you found the fasciitis, plantar fasciitis problems, maybe it can make the gastrocnemius muscles spasm or the pain on the Achilles tendons itself. And then please use always gel because Gel makes the rub on the shockwave therapy is more lighter than if you were not use the gel. And this is some journals that support for the using shockwave therapy. First, the effectiveness of the shockwave therapy on the calcified and non-calcified tendinopathy of the shoulders. The conclusions is the effectiveness of the shockwaves in the treatment of the shoulders, it better results. And then this is the effect of the combined treatment for the shockwave therapy and the stabilization exercise. The combined therapy group of the shockwave therapy and the exercise showed statistically significant improvements in all visual analog scales and CMS evaluations items. And then this is for the extracorporeal shockwave therapy for the trochanteric pain syndromes. The conclusions is the shockwave therapy is an effective treatment for the greater trochanteric pain syndrome. Of course, for the chronic plantar fasciitis treated with 2 sessions, in only 2 sessions with the 2000 impulses, each 1 week apart, he found that the shockwave therapy was successful. And this is one is the shockwave therapy in the spasticity in the cerebral palsy. It shows that the shockwave therapy is more effective than placebo in decreasing spasticity of patients with cerebral palsy. This is the efficacy and the safety treating chronic non-specific low back pain with shockwave therapy combined with the drugs. It shows that the patients treated with the shockwave therapy had significantly lower means the numbering rating scale for the pain than the patients treated with the shockwave therapy and combined celecoxib and eperison. Okay, that's all that I can share to you. Thank you. Back to the
Thank you, Dr.
Dr.
Yudit, for your wonderful presentation. And it was delightedly very knowledgeable. And even though it's a, like shockwave therapy is a very new concept in physiotherapy, and I'm obliged that you have addressed this new technology. And thank you once again for your time
Thank you.
for this conference. And thank you.
Thank you, Dr. Ankit.
So now we can proceed with our next speaker, Professor Dr. Zafar. He's a renowned scientist and researcher and clinician from Ghaziabad. I warm welcome you, sir, and thank you so much for your time. Thank you, sir.
Very good morning to all. I am Dr. Zafar from Galgotia University and a private practitioner in the Ghaziabad. And I run my own clinic. And here I am working in the Galgotia University as a professor and the program chair. Here under my belt, I am running 4 programs, that is PG in sports medicine, PG in neurology and orthopedics and cardiology. So I will discuss my presentation on the meniscus injury. So I am going to share my slides. Yes. I'm having problem in uploading this.
So in the meantime, you can start your presentation. If it gets shared, that would be fine.
Yes, sir. I'm going to share with Dr. Ankit.
क्लास में कनेक्ट नहीं हो पा रहा था
I have shared my PPT to Dr. Ankit. I think he will be able to
Uh,
upload
s-
in the program. And now I'm going to start.
no, sir,
Yeah.
one minute.
The
There
word
only you will
meniscus
get
comes
an
from the Greek
option of
word.
sharing the screen.
Okay. Uh,
There only you will get an option of sharing the
I have
screen.
tried, but it is not coming. Sharing screen is not visible. It's a mute, stop, setting, presentation. In the presentation, if I go, but slide share from the computer.
सर, आ- आपके वहां पे एक प्रेजेंट का ऑप्शन आ रहा होगा। उस प्रेजेंट के ऑप्शन पे जब आप क्लिक करेंगे
Yes, sir.
तो
I
वहां पे
think
आपको शेयर स्क्रीन आएगा।
मैंने सर मैंने उसी पे जाके किया है, प्रेजेंट पे जाकर के। आई थिंक वो
अच्छा,
मैंने डाल तो दिया है इसमें।
ठीक है, एक बार आप या तो मुझे मेल कर दीजिए, मैं उसको यहाँ
मैंने
से करता हूँ।
सर मैंने कर दिया, आपको भेज दिया है। बट इट इज नॉट कमिंग।
सर आप जब तक स्टार्ट करिए, मैं प्रेजेंटेशन आपका निकलता हूँ।
ठीक ठीक है सर, ठीक है, ठीक है। So the meniscus is a very important part of the knee joints, which play a very vital role in the knee point, and especially whatever the games you play. If there is an injury, so first of all, we will just say about this. The objective of this program is to the knee the anatomy, synovial fluids, meniscus tear, diagnosis, plot, treatment plan, conservative and surgical procedure, rehabilitation, meniscus, and return to work. So if someone gets the injury at this level, the meniscus, he or she will not be able to perform according to the required, because there is a catching point in the knee joints which locks the knee. This is the main classical feature of the meniscus tear. So again, if we go for the anatomical part, knee joint is made up of the distal part of the femur bone and the proximal part of the tibia and fibula at the knee joint. Knee is a hinge type of joint. I think everyone know the four ligaments ACL, PCL, MCL which bind the knee joints. These ligaments bind the knee joints and give stability to the knee joints. Meniscus lies in between the joint space. Synovial fluid is present in the knee joint space for the lubrication of the knee joints and protect the knee joint, reduce the friction of the knee. So synovial fluid contains the hyaluronic and which is secreted by the fibroblast like cells present in the synovial membrane. Synovial fluid contains proteoglycans for and lubricants secreted by the chondrocyte surface present in the articular cartilage and interstitial third written from the picture, I think it is shared. You see, a meniscus is C-shaped structure. Meniscus cartilage has the both bony cartilage, bony attachment to the tibia and attachment to the surrounding knee capsule. So this is the figure which I think, if it is shared, then you can see that how the meniscus is going. Effective articulation and the respective convex femoral condyle. This the inferior surface, the flat accommodates the tibia plateau. So this is about how your knee is going to function. If you get any injury at this part, then how it is going to lateral and the medial menisci is attained between the 8th and 10th week of the gestation, how it is going to form in the body. So developing menisci is a highly cellular and vascular with the blood supply entering the periphery and extending through the entire width of the menisci. So at the fetus, so it is about the how it is going to develop when the child is in the mother's womb. If fetus continue to develop, there is a gradual decrease in the cellularity and of the menisci with a consistent content in the circumferential arrangement. Joint motion of the postnatal stress. Postnatal stress of the weight bearing are important factor in determining the orientation of the collagen fibers. By attending only peripheral 10 to 30% has the blood supply. So we must note only the 10 to 13% of blood supply in the meniscus area. We'll go to the another slide. So this is the anatomical structure. If you find this, so how it is going to showing on your screen. It's a very important part. If you see, there is a meniscus and there is an anterior cruciate ligaments which is showing in the this slide. So transverse intermediate ligaments is there, lateral menisci is there, and the ligaments of the Wisberg is there. Posterior cruciate ligament is there, medial menisci seen here, and medius collateral ligament is also seen in your screen. So if you go and see only the vascularity, about the vascularity, the menisci is relatively a vascular structure. So we know this structure doesn't have a blood supply. So with a limited peripheral blood supply, the medial lateral, so the medial lateral and the middle geniculate arteries, which branch of the popliteal artery, provide the major vascularization to the inferior and the super aspects of each menisci. The peripheral 10 to 13% of meniscal menisci border with 10 to 25% lateral menisci are relatively well vascularized. So it is about the how the vascularity in between in the menisci. So which is important implication of the meniscus healing. If someone is getting injury, the how your meniscus is going to help. So embryological and the development of the menisci, the say the semicircular medial menisci measures approximately 35 mm of the diameter anterior to the posterior is significant broader posteriorly than it is anteriorly. So where is meniscus friction? What is the function of the menisci? To prevent arterial frictions, load bearing, increase contact area, reduce contact stress, shock absorber. Menisci play a vital role in articulating in attenuating the intermittent shock wave generated by the impulse loading in the knee with a normal gait. So according to Wisnoy and Vosk, that a normal knee has a shock absorbing capacity about 25% higher than the knee and have undergone any meniscectomy. So joint stability, how it is going to produce the joint stability? Menisci provides an important role in the maintaining joint continuity and stability. The superior surface of the menisci concave, enabling the effective and articulation between the concave femoral condyle and the flat tibia plateau, which the menisci is intact axial loading of the knee in the multi-directional stability function in the motion in all the directions. So how it is going to when the meniscus tear is there, an estimated 80 to 9% meniscal injuries are associated with athletic activities and are often seen in the conjugation with other accurate injuries such as the anterior cruciate ligament. So along with whenever there you have the injuries, then chances of the ACL is going to also happens there. Tear is happened there. So condral injuries may be there. So tibial fracture may be also one of the common injuries when you are in the sports or or some, in the old age. This is also very common. Very common in the sports person while playing the games, especially high speed games are reported. Whenever you high speed is games, there is chances of the meniscal tear and other injuries are associated with this. So football, rugby, lawn tennis, badminton, cricket, kabaddi, long jump, shot put throw, javelin throw, etc. And meniscus tear is due to twisting of the knee joints in the young players is common, and the tear is vertical in young adults. So it is very important part here it is. So there is a chance of the vertical tear in the young adults and horizontal tears in the old person. This is the basic difference between the old and the new old person and the young adult. So meniscal tear is very common in compared to lateral meniscal tear, and then along with that medial meniscus is more there is will find the medial meniscus is more common tear in compared to lateral meniscus tear. Any activity that causes the forceful twist or rotation of the knee joint, such as aggressive pivoting and sudden atop and turn, even kneeling, deep squatting and lifting something heavy may somehow lead to torn the menisci. So longitudinal, vertical, and bucket handle tear. This will be also happen. So bucket handle menisci tear is serious injuries that occurs when the menisci separates around the circumference and the inner margin becomes displaced. Meniscus tear associated with the anterior cruciate ligament. This is very common. Whenever you have the meniscus tear, there is chances of the anterior ligament tear is also very we will see in file. So this is the meniscus, how it is going. In another slide, you come for the downward slides. You will see how your slide. You will see the findings of the how the your meniscus is going to tear. In the different slides, if it is visible, then it's very you can find how it is going to show it. So meniscus tear, this is meniscus tear in the children and adolescents. So if we complex in the children, that is 3.1 2.5% 9, and the vertical tear may be 1.6, and in adolescents is 3.7. That 19% of the population will get having the this tear, and total is 5.53 and 16% of the tear. And discoid may be 32% children, and that is 25%, and 14% adolescent, that is the 7 total injuries of the 7%. So bucket handle tear may be 10%, and in case of the adolescent, it is called 32%. So this is the graphic presentation how your tear is going to happen in the children and the adolescents total. So we can find all the things. So this is about this. So we'll go to the next slide. So muscularity associated with the what's happening. So the muscular tear may be happen. It causes the this meniscus tear associated with the ACL. That causes the pain, swelling, range of motion will be decreases. Classical features, there is classical locking of the knee joint. This is the main classical feature of this tear is locking of the knee joint, possibly catching point. So you will be unable to extend your knee and flexing while flexing and then extending the knee joints. So it becomes will become the catching, and you will feel close. Pain is so much high that you will not put your whole weight on the knee joints. So difficult on the deep knee bending and locking of the knee in partial flexion. So this is about this, how your knee is going to behave when you have the meniscal tear. So if you want to go for this diagnostic part, if clinically suspicious meniscal tear, total conservative management may be considered or confirmation of the magnetic resonance imaging. So we will go for the MRI. So in the MRI, you can find the different type of tear which is going to which is have been happened, and that can be seen in the MRI. Unfortunately, general practices cannot currently order the MRI funded MRI. So what has happened is if someone goes for the natural to the any physician or someone else, they used to treat as a very in not in a very serious manner. This okay, you will get it okay, but when the problem is not solving, so then they move to the any orthopedic surgeon or any of the physiotherapists. So they will find what the main reason behind this. So if you find all these things, so then you go for the critical examination of the knee joints. Then you will come to know what are the critical exams. The critical examinations are there is swelling, with gross swelling may be there, rise of temperature maybe happen in the knee joints, and locking of the knee joints. So this is the main classical feature, and the pain will be so high. He or she, the patient will, maybe male or female, he or she will not be able to put his weight on the knee joint. So this is the main problem of the knee joint. So differential diagnosis, if you want to go for the differential diagnosis, tear when typically in young patient with the horizontal in the elderly. So vertical in the young patients or young athletes, and vertical maybe horizontal in the elderly patients, which I have already told. So differential diagnosis you want to do, then the osteoarthritis check the crept sounds, swelling, range of the knee and gait, ACL anterior draw test, maybe checking for the ACL injuries, locking of the knee in a straight gait in the straightening, and the gait you can also check with the gait training, and facial posterior draw test and MCL valgus draw test can be checked. So in this way, and the range of motion will be decreased. Flexion of the knee in the into 90 degree is extremely rotating at the tibia. So this is when you go for the MCL injury. So if someone is having MCL injury, then you will have to check all these things.
Zafar
The portion
sir,
of the knee causes
Zafar
relaxation
sir,
and of the cruciate while the collateral ligaments are tight. जी सर.
जफर सर, सॉरी टू इंटरप्ट, आपकी स्लाइड्स अब
हेलो.
स्क्रीन पे हैं, तो आप बता दीजिए कौन
हेलो.
सी स्लाइड स्क्रीन पे लानी है।
अच्छा, ठीक है सर, ये स्लाइड नंबर है हमारा 15. 15 पे हम लोग हैं, 15 पे डायग्नोसिस ऑफ द मेनिस्कस टियर. डायग्नोसिस ऑफ द मेनिस्कस
सर
टियर,
आ गया
दैट इज
स्लाइड पे,
स्लाइड
आ
नंबर
गई है
15.
स्क्रीन पे।
आ गया, ठीक है सर. This is the how you are going to diagnose. So I am on the slide number 15. Then after that we'll proceed for the next slide. So LCL injury, and if you want to check with all the ligaments along with the meniscus injury, so you have to check with the ligament injuries test. So varus draw test for the LCL injuries. Hamstring pull may be there. Limping gaits, unable to straight the legs and cause hamstring pull due to the pull of the hamstring muscle. So these are the diagnostic part. If you go for the diagnosis, then you will be very easily you can diagnose this meniscus along with this ligament tear. If you have the broad knowledge of all this, then it will be very easy for you, for the therapist, for the physiotherapist and orthopedic surgeon. They can diagnose, and the treatment part will be very easier. So we'll go for the next slide, sir. So diagnosis, this is another slide number 16. If clinically suspicious meniscus, a total conservative management may be considered for the confirmation and magnetic resonance. So if you want to go for the conservative management, then you have to check with this MRI. Unfortunately, general practitioners cannot currently order the Medicare funded MRI. Clinical diagnosis meniscus tear and an applet test. So you can go for the applet test. The patient lying prone with their knee flexed to the 90 degree and the hip is extended. The clinician applies axial pressure to the knee, to the foot, and rotate the tibia internally and externally. Pain and clicking of the compression suggests the meniscus tear. So this is about how you are going to diagnose the meniscal tear. So we'll go for. So diagnosis meniscus tear. This is another test. The Thalset is the clinician hold the patient's outstretched hand for the support while the patient stands flat foot and the knee flexed to 20 degree and rotates their body in the knee time and with the knee 3 times. Positive if the symptoms are reproduced of the under rotation. So if you do this 3 times while this test, then if there will be any pain, so there will be flexion of the knee joints, and one leg is again has been put apart from the ground. So while you're performing this test, then you will come to know if the pain is produced and all things happens. So then you will to diagnose that meniscal tear. So treatment plan.
आई थिंक जफर सर का इंटरनेट गड़बड़ हुआ है। लेट मी चेक। शायद कनेक्शन प्रॉब्लम हुआ है. हाँ, he is connected now. And technical team, please share his slides.
In a very short, we will again.
सर 1 मिनट, आपकी स्लाइड शेयर कर रहे हैं वापस से, तो
Sir,
आप
share the
बताइए
slide.
जो 16 नंबर के आगे करना है.
अंकित सर.
हाँ जी
सर स्लाइड नंबर है हमारा. जी सर, स्लाइड नंबर
16 राइट.
again we will go for back from the 17, slide number 17.
17 प्लीज टेक्निकल टीम प्लीज 17 नंबर स्लाइड शेयर करिए.
Yes sir. Yes sir, 17. 16. Yes sir. Yes sir, 17 नंबर स्लाइड से.
जी सर, आप स्टार्ट कर सकते हैं सर, आपकी स्लाइड आ गई है.
ठीक है सर, आ गई है ना सर. मैं 17 स्लाइड पे जा रहा हूँ सर. दिस इज अनदर टेस्ट. सो हाउ आई हैव ऑलरेडी discuss the clinical diagnosis of meniscus tear, that is by the upper test, and this is another test called Thalsey test. So Thalsey, the clinician hold the patient outstretched hand. So you will have to again catch the hand of the subject at a stand. So patient has to stand and flat footed with the knee flexed to 20 degree and rotate their body and the knee 3 times. So you have to rotate the patients into 3 times, that is in the internally and externally. The test is positive. If you have any pain in something, the test will be positive. So the positive symptoms if they reproduce on the rotation. So this is another test. So you have the apply test. So again we have the Thalsey test. These are the 2 tests. By this we can diagnose the meniscus tear by the clinically. So we'll go for the slide number 18. So treatment plan. So how you are going to treat this plan? If you go because we are in the conservative management, if there is a grade 1 tear, so we have came to know during the slide previous slides. So there is a minimal supply of the blood in the menisci, and menisci is just work like as a shock absorber to the knee joints. So in this part we go for the treatment plan. So for the conservative management and for the surgical management, both management is there. So it depends upon the tear, which type of tear the patient is suffering or sports person is suffering. So we will go for the, if we go for the conservative management, so for the price, so we say price. So what is the price? Price is stand for the protect, rest, ice. First 48 hours is ice is very effective. Compression either by the crepe bandage or the knee brace, we can use this one. Elevation, so leg should be elevated, putting pillow under the knee and the heel. So anti-inflammatory drug is also prescribed. So it is again part of the orthopedic surgeon. So this may be also considered. Physiotherapy, part of the physiotherapy, knee mobilization is used by using the knee brace. Kineso tape is used to stabilize the knee muscles and knee movements, where to reduce the swelling. So how it will help? It will reduce the pain. Application of the spike of the 48 hours is very effective. Bandaging of the knee joints by the crepe bandage or Kineso tape is used to fix the knee movements. Menisci pain is treated by the laser also. We can also treat the laser, because laser will again very effectively by the biomodulation biomodulation therapy, which have the deep penetration class 4 laser that produces the very deep deep penetration lasers. Earlier we used to have a class 3 laser, but now many of the hospitals having the class 4. So class 4 has been the better result in compared to the class 3B lasers. So which reduces swelling and increase the blood supply in the affected part. Healing process will be fast. Process will be fast due to its biomodulation. So increase the strength of the knee joint. So again we have to go for the quadriceps and hamstring muscles by static and dynamic strengthening of the quadriceps table on the quadriceps table, or rather the static, or by putting the pillow or the roll of the towel. And again patient is asked to do for the contraction and relaxation phase. By this way we can also reduce the swelling at the knee joints, and quadriceps can be demonstrated as we can see the treatment, how you are going to treat your patients. If it comes to you, how we are showing you here the application of the ice packs, how it is again the bracing part, and how you keep your legs under the pillow. That will again effectively, and it will reduce the swelling. And again the knee taping is also used here. And again again in the next slide, in the connective slide, you can see the patient is again examined by the therapist. And here again we can see the and in the slide we can see the how the patient is behaving. So, in slide number 20, so again the surgical treatment plan. So PSC checkup is required. That is not our part, but we can know all these things. And PSC is like, again checkup by the anesthetist, and that is the CTBT test, complete hemogram test, chest X-ray, PAView. Because if the patient is an old person, then he has to stay for the long hours in the long stay in the hospital. So his chest must be clear. So again, chest physiotherapy is required if there is any congestion or any secretion in the lungs. So blood, if the patient is diabetic, again the checking will be the fasting and PP. And for the diabetic condition, blood pressure, blood urea, all these parameters are the normal. The surgeon will go for the surgical procedure, arthroscopic surgery for the removal and suturing of the tear meniscus according to the required procedure on the spot in the OT. So this is again, this is the surgical procedure that is, but we must know how it is going to help. So here we are going to say about the surgical treatment plan. Arthroscopic surgery, a keyhole surgery is to remove the debris, that is a part of the removal from the knee joints, which make the hindrance in the knee movement. So this is again Abhinav. So again we have to check, this is part surgical movement. So this is the surgical part, but we must know after post surgery you have to treat the patient for the strengthening and the knee joint. So again, the drug may be anti-inflammatory drug, that is again given by the any of the orthopedic surgeon, and the 1BD and initial and later SOS. So it may be because antibiotics is prescribed by the amikacin, a choice of the drug by the majority of the surgeon. B complex, again 1 OD may be prescribed, supplementation of the calcium, glucosamine. All these drugs are prescribed post surgery for 2 weeks. Elevation of the leg will then put the post surgery ankle pumping exercise again to prevent the DVTs. Surgical stitch is removed after 2 weeks. So rehabilitation part now again starts with therapy treatment that is required 4 to 8 weeks. Static participant exercise that is 10 to 20 repetitions per day, gradually to increase the advancement of the recovery. Ankle pumping exercise again 10 to 20 repetitions per day, gradually can be increased to progress recovery. And gait training also part of this part, where whenever you surgical stitches and when you get better recovery, then gait training will be performed, because most of the patients who are suffering from the meniscus injury, they used to lost the gait training. So again we have another role, how to teach them the gait. Gait training is a very important part, and non-initial weight bearing, that is auxiliary crutch or the invalid walker, is used for the gait training. So now we'll go for another slide, that's slide number 22. That is the post-surgical rehabilitation, climbing training, knee loading training to increase the strength of the knee, muscle joint, and ADL activities of ADL activity of daily living trainings. So weekly assessment is required to assess the progress of the subjects back to normalcy and return to the sports work. So this is about this how. Now sir, it's finished, and this is about the references, and, and from my side, thank you sir.
Thank you so much, sir, for your time. And it's really a knowledgeful session. And thank you so much again. Now let's move to our next eminent speaker, Dr. Jasprit Kaur. She is a associate professor from Department of Physiotherapy, Guru Jambeshwar University, Hisar. And thank you so much, ma'am, for your time. And I warm welcome you for this session. Thank you.
Thank you, Dr. Ankit, for inviting me. And first of all, I would like to thank organizers for inviting me inviting me as a speaker. Now I'm sharing my slides.
मैम प्रेजेंट वाले ऑप्शन पे क्लिक करिएगा, वहां पे शेयर स्क्रीन का ऑप्शन आएगा.
ठीक है सर. Is it visible, sir?
Yes, ma'am. Yes, ma'am.
Okay. Good morning to all the students and delegates present here in the conference today. So the topic of my speech today is current approaches to treat cervicogenic headache. First of all, myself, Dr. Jasprit, I'm Associate Professor, Guru Jambeshwar University of Science and Technology. So headache has become one of the common disorders of nervous system, and approximately globally it is 47% of the patients suffer from this disorder, and this is a syndrome, not a disease. And secondly, it is one of the unilateral headaches, which is like side lock. Patient feels pain on one side of the head and neck, and it can move towards contralateral side only if the severity of the headache increases, and even if it is left untreated. So when we talk about the pain, we're talking only about cervicogenic headache. We have several types of other headaches also. So we won't go into details of that. So only talking about the pain which is being felt by the patient in cervicogenic headache. There are four main things that we need to see in this. Our first is type of pain, duration of pain, what provokes the pain, and how is pain precipitated. The type of pain here is very mild to moderate in intensity, dull, non-pulsating, and non-throbbing. Duration can be from few hours to few months and several days also if left untreated. Provocation can be movement of neck, coughing, sneezing, keeping head in awkward positions. Pain is precipitated by external pressure on tender points on symptomatic side like C2, greater occipital nerve, and transverse process of C4 and C5. So what are features of cervicogenic headache are basically reduced range of motion, stiffness, vertigo, stiffness over upper cervical areas सबसे पहले पेशेंट को स्लीप डिस्टर्बेंसेस हो सकती हैं, रिथमा फील हो सकता है on forehead and temporal region, and also patient can have symptoms similar or mimics like migraine में जैसे nausea, vomiting, loss of appetite, photophobia, phonophobia etc. ये होता है. Patient can mimic symptoms can mimic migraine. Now, other symptom that patient can tell you about is the trigger point present on the trapezius. When you examine the patient, you will find some trigger points in these particular muscles, like upper trapezius, levator scapulis, sclenes, and suboccipital extensors. Few muscles are tight, and few muscles can have weakness. For example, weakness can be felt in deep neck flexors. Activity can be increased. You can find increase in superficial flexors. Similarly, you can find atrophy and various impairments in the muscles of the neck. So now, because we have several type of headaches, how is it differentiated from the other type of headache? This has been introduced by International Headache Society by giving International Classification of Headache Disorders. It was given in 1988 and then it was revised several times till 2018 now. So the main criteria laid down was on these four main points, and first of all, first point was like pain in neck. ठीक है, और जो हेडेक जो पेन है वो आपको मोर देन वन पॉइंट इन हेड और फेस में फील होगा. और दूसरा है कि जब भी आप किसी टाइप का क्लिनिकल लेबोरेटरी इमेजिंग कराएंगे तो उसमें आपको सर्वाइकल लीजन या सॉफ्ट टिश्यू में कुछ ना कुछ अबनॉर्मेलिटी मिलेगी. दूसरा, जब भी आपका नेक डिसऑर्डर है या लीजन है उसमें जो है डेमोन्स्ट्रेशन ऑफ क्लिनिकल साइंस होने चाहिए टू इम्प्लीकेट सोर्स ऑफ पेन. दूसरा, अगर नर्व ब्लॉकेट से या डायग्नोस्टिक ब्लॉकेट से पेन कम हो रहा है देन इट इज पॉजिटिव फॉर सर्वाइकोजेनिक हेडेक. और दूसरा कि अगर 3 महीने सक्सेसफुली आपने ट्रीटमेंट किया है ऑफ द पॉजिटिव डिसऑर्डर, अगर पेन चला गया है देन इट इज सर्वाइकोजेनिक हेडेक. सो व्हाट इज द पैथोफिजियोलॉजी, वी आर नॉट गोइंग इनटू मच डिटेल्स, बट एक पॉइंट है जो समझना बहुत जरूरी है, दैट इज कन्वर्जेंस ऑफ ट्राइजेमिनल फाइबर्स एंड अपर सर्वाइकल नर्व. If you can see this diagram, we'll be only discussing the diagram. You can see the cervical nerves here and the trigeminal nerve का जो supply है on the face and forehead. Now what happens is exactly कि जो आपके cervical efferents में nociceptors हैं वहाँ पे cervical region में, वो उनका density बहुत कम है, whereas density of nociceptors of trigeminal nerve are quite high. तो होता क्या है कि व्हाट इज कन्वर्जेंस ऑफ बोथ. हमें कन्वर्जेंस का क्या मतलब है कि एफरेंट्स जो है यहाँ से फाइबर्स निकल के जाते हैं सेकेंड ऑर्डर न्यूरॉन ऑफ द डोर्सल हॉर्न. सिमिलरली ऑफ्थेल्मिक नर्व भी comes towards this second order neuron of the dorsal horn of the cervical spine. यहाँ से फिर ये दोनों मिलके they move towards the cerebral cortex. Now the great thing that you can see here is the trigeminal nucleus, which is extending all the way from the midbrain to the spinal cord. अब ये nucleus बहुत बड़ा होता है. This is the only nerve which has the largest nucleus present in the brain. Now अब brain में क्या हुआ, जैसे ही ये symptoms signals brain को पहुंचे sensory, the brain processes the signals. पर यहाँ पर एक थोड़ा processing error आ जाता है because ब्रेन को ये पता है कि जहां पे नोसिसेप्टर ज्यादा है वहां पेन सिम्टम ज्यादा जाएंगे. तो जो फेस में आपके ऑफ्थेल्मिक ट्राइजेमिनल नर्व के नोसिसेप्टर ज्यादा है, तो जो ब्रेन है वो पेन के सिम्टम्स आते हैं टुवर्ड्स द फोरहेड एंड द फेस रादर देन पर्टिकुलरली ऑन द नेक. सो दिस इज द कन्वर्जेंस ऑफ द ट्राइजेमिनल नर्व एंड सर्वाइकल नर्व्स. दूसरी बात यह है कि जो पेशेंट को पेन फील होता है, मैक्सिमम फील होता है ऑन द फ्रंटल लोब एंड द ऑर्बिटल रीजन. व्हाई नॉट ऑन द अदर पार्ट ऑफ द फेस वेयर यू हैव ट्राइजेमिनल नर्व की तो ब्रांचेस आपके मैक्सिलरी रीजन पर भी जा रही हैं, मैंडिबुलर रीजन पे भी जा रही हैं, तो यहाँ पेन क्यों नहीं फील होता? बिकॉज जो आपकी नर्व है, ठीक है, इसके न्यूक्लियस के 3 पार्ट्स हैं, पार्स ऑर्बेलिस ऑरेलिस, पार्स इंटरपोलैरिस, पार्स कॉर्डेलिस. अब ये इन्वर्टेड है. इन्वर्टेड कैसे? कि जो आपकी मैक्सिलरी और मैंडिबुलर नर्व है वो तो जाके इंसर्ट कर रहे हैं आपके पार्स ऑर्बेलिस और इंटरपोलैरिस पे, जो सर्वाइकल स्पाइन के न्यूरॉन से काफी दूर है. वेयर एज योर ऑफ्थेल्मिक नर्व जो है, it is going towards the pars caudalis, which is exactly on the cervical C2 spine, and this directly goes to the spine, and that rest of the thing I have explained. So this is the reason that why we feel pain more on the forehead rather than pain on the neck, क्योंकि हमारे नोसिसेप्टर्स जो है वो नेक में जो मसल्स हैं उन पे कम हैं रीजन पे, सर्वाइकल रीजन पे, वेयर एज ऑन फेस दे आर क्वाइट हाई. Other reasons are like segmental hypomobility due to stiffness of the neck, muscular impairments, entrapments of several nerves like occipital nerve. Okay, and the entrapment irritation of occipital nerve you can find out, and in which include both lesser and greater auricular nerves also. The pain perceived by forehead ज़्यादा होता है, मैंने बताया भी आपको. Similarly, pain perceived over the occipital region up to the coronal suture is due to convergence between one cervical afferent to the other cervical afferent. So now we come to management. Management दोनों तरीके से है, pharmacological and non-pharmacological. Pharmacological you can find pregabalin, NSAIDs, etc. You can find percutaneous cryoneurolysis and pulsed radiofrequency and epidural steroid injections. Cervical plexus block. Then you have anterior cervical spine surgery and occipital nerve block. And lastly, you can have botulinum toxins. Now we come to physiotherapy management. We have 3 main management. First is manipulation, mobilization, and posture correction. A lot of research has been done on these things, and it has been found that all the 3 things can improve the symptoms of cervicogenic headache. So manipulation may we have firstly cervical rotation manipulation, which will include C2 rotation correction manipulation and C2 lateral translation correction manipulation. तो अगर हम C2 rotation correction manipulation देखें तो I have little video of some seconds. You can find out that this is how the therapist has webbed his hand on the C2 vertebrae spinous process and hold the chin of the patient and rotated the spine to the maximum rotation can be felt. And you must have heard little click sound, which is the manipulation at the C2 rotation. Then you have C2 lateral translation correction. You can see the therapist has how the placement of the hands of the therapist, and he has webbed the transverse process of the cervical spine, and he has translated this laterally, and then the manipulation was given. Manipulation is basically high thrust, high velocity thrust. So then you have upper cervical that we have already given, and there is thoracic spinal manipulation. It can be given in this way. Rather than reading, I must show you the practical part. The therapist has hooked the particular level of the spine, thoracic region. And you can see that the therapist has then asked the patient to fold the arms around the shoulder. And then with the Xiphi sternum and the chest, he gives the pressure over the elbows of the patient, and then the high velocity thrust is given on the thoracic spine.
Breathe in, breathe out.
Okay, so this was the thoracic manipulation. Rest mobilizations are C1, C2 snag rotation, C1, C2 snag rotation by the therapist, then central PA to C2, C3, unilateral PA to C2, C3, upper cervical translateric glide. I hope I'm audible.
Yes, ma'am.
Okay. So snags, as you know, that it has been given by Brian Mulligans. So this is the cervical snag given by patient himself. What is done in this is that a belt or a towel is taken, and it is kept on a particular level, and the spine is pushed forwards with the rotation of the cervical spine. Similarly, this is the same mobilization given by the therapist, and the patient actively rotates the neck. This is the PA glide or the central glide to the patient, which is given on the transverse process. This is Maitland's glide basically, and it is given in the PA direction. And then after judging the area of the resistance, the glide is given or the oscillations are given according to the grade of the judged by the therapist. And then this is the translatoric glide in which the therapist holds the occiput of the patient and makes a key type of grip on the spinous process. And then he rotates and side flex the thoracic spine by mobilizing the level to be mobilized. This is the lateral PA glide, which is given on the zygoepiphyseal joint or facet joint as it was given on the spinous process. Now, these are the reasons that why after giving mobilizations that we must have got this, or the patient has relieved the symptoms like the activation of joint efferent activities or inhibition of the pain at spinal cord level. It may have reduced inflammatory substances, decreased pain sensitivity and spinal excitability, modification of cortical area involved in brain processing. There is a spinal release of serotonin and non-adrenaline from the descending neurons, which may also mediate pain modulatory effects. Then we have various posture correction exercises. Some muscles, like I've already told you, are tight and some are weak. So the tight muscles are suboccipital extensors, upper trapezius, levator scapulis, scalenes, sternocleidomastoid, pectoris major, whereas weak muscles are deep cervical flexors, rhomboides, middle trapezius, serratus anterior, deep flexors of the neck. So on all this, we had recently done a research. One of my PhD scholars, she has done a great work on this thing, and we have published papers on treatment of cervicogenic headache. We have used all mobilizations along with the neural mobilization also. We had mobilized trigeminal nerve and found that it is really gives positive effects to the patient, and patient is relieved from the pain, especially on the forehead and the occipital area. So these have been published in the journals of repute. And the future, what I suggest to all the students who are in research or the masters and PhD students here, that you can further go for optimization of the manual therapy protocols, not only for CGS. I'm suggesting you for all the types of ailments that are being treated with manual therapy. And the treatment should focus on the patient-centric approach. Like the types of the symptoms that patient is getting to you, not giving all the mobilization, all the manipulation to one patient. It should be like patient-centric approach for the treatment. Thank you so much. Thank you for being good listeners. Thank you.
Thank you so much, ma'am. It's indeed a knowledgeable session, and as we know, manual therapy is our main part of the treatment in physiotherapy, and you have really covered a topic which actually needs in the market to know to the new students. And thank you so much for your time, ma'am, and
Thank you
for
so
this knowledgeable session. Thank you, ma'am. So we'll move forward, and we have next eminent speaker with us, Dr. R.K. Mudgal. He is a senior faculty in DIPSR in Delhi, and he's also the president of HCAP. So I warm welcome you, sir, for your knowledgeable session. And please, can you unmute? Yeah. Warm welcome you, sir. Thank you.
Thank you, sir. First of all, thank you to the Jyoti Vidyapeeth University for giving me such opportunity to present here in front all of the dignitaries present in the dais, or you can say on screen. Thank you. My topic is screen is visible.
अभी नहीं हुआ है शेयर.
Screen there. No, Zoom नहीं, StreamYard. I think from my side, it's sharing.
अभी एक मिनट, अभी तो यहाँ तो नहीं आया है, एक बार देखते हैं, हो सकता टाइम लैग हो। आपके वहां से शेयर हुआ
Yes.
स्क्रीन?
Yes. Entire screen. I think entire screen is the option, na?
Entire, just click on it.
हो जाए screen is visible. Hello. आई थी एक सेकंड अब ठीक है यू कैन सी माय प्रेजेंटेशन थैंक यू My today's topic is current scenario of physiotherapy practice in India with special reference to the legal aspects because the legal aspect is the most ignorant sector in our daily routine practice. We everyone know about the techniques, we everyone know about the protocols, but on the front of legal aspect we have so many lacunas. So the outline of talk is the routine introduction and branches importance. These all things we already discussed in so many lectures. But the main is the brief history about the profession, present situation of physiotherapy education in India, regulatory authorities at present, what is the council, structure of council, existing state physiotherapy councils in India, function and responsibility of council, need, and the most new one, the state allied and healthcare council. As we discuss about the introduction, we all know the WCPT, World Confederation of Physical Therapy, is already defined us very well. Next, the International Standard Classification of Occupation provide a different code to us. This code separate us from the paramedics, but in most of the state we already considered as a paramedics, but we are different from them because we have different code as per international standards. These are the branches we all know: musculoskeletal, cardiothoracic, neurological, in rehabilitation, sports, in fitness, pediatrics, geriatrics, and the new one is the physiotherapy for astronauts. Basically, in zero gravity planes, the physiotherapy is most effective to train the astronauts. Importance we all know. I don't think so. We discuss history. This one is must because ancient times, signs of people being treated with the use of physical agents and manual therapy. In ancient time, antediluvian time, the oldest reference of physiotherapy through manual therapy traces back to the Srimad Bhagavad Mahapuranam, an ancient Indian religious literature written between 1300 BC to 2000 BC, describing several Hindu mythological epics. One of the description tells of Lord Krishna correcting the spinal deformity of one of his devotee named Kubs by applying a manipulation technique. Cobb's back was deformed in 3 places, having scoliosis or kyphoscoliosis with one primary and 2 secondary curves. And this is already discussed in the book written by Mohanty Uma Shankar, the ex-IAP president, and one of the research paper also published by me, and all already present in the reputed conference by Arthur Ridakar, a Nobel Prize winner, in front of him. The famous Indian physician Shushruta also gave us so many techniques. In his book Shushruta Samhita, written in 1600 BC, is one of the most compressive territories of the entire medical disciplines, and whose detailed description of surgery and medicine are relevant. बेसिकली आप देखेंगे जितने भी मेडिकल कॉलेजेस हैं सुश्रुत संहिता, उनमें जितने भी आपके आयुर्वेदिक कॉलेज हैं, बीएमएस कॉलेज हैं, उनके लिए वो एक बाइबल की तरह, कुरान की तरह, गीता की तरह काम करने वाला जो ग्रंथ है, तो बेसिकली उसमें भी हमारे ट्रेसेस हैं. बट अनफॉर्चुनेटली और फॉर्चुनेटली जब हम रिसेंट टाइम में जब हम डिस्कस करते हैं तो ज्यादा से ज्यादा हम वर्ल्ड वॉर 2 तक पहुंचते हैं, वर्ल्ड वॉर 1 तक पहुंचते हैं और मैरी मैकमिलन तक ही सीमित रह गए हैं, जो कि सही नहीं है. We should know about our past, we should know about our history, a very well explained history written in so many books. Yoga is another domain which has had strong links with physiotherapy in country steeped in tradition and rich culture. We have 1800 different exercises that help a person to slowly recover from an illness or disease. While yoga origin can be traced 5000 years ago, but when we discuss about the modern history, the physiotherapy took a firm base around World War I, when surgery gave rise to the new branch of orthopedic with improved treatment techniques and followed by the rehabilitation of the injured shoulder. The foundation of physiotherapy was laid in India in 1952, following a major epidemic of poliomyelitis in Mumbai, and soon in 1953, the first school and center of physiotherapy was established in Mumbai as a joint collaborative project of Government of India, state government, and the Bombay Municipal Corporation, with technical support of World Health Organization, as we know, WHO. So these are some modern traces. At present, in present situation, we have 911 university as per the updated list of the University Grant Commission, in which around 400 state universities, 126 deemed to be universities, 48 central universities, and 337 private universities are present across India, in which around 390 different institutes were running physiotherapy courses in their campus. And as we know, there is a huge number, 390 different institutes all over the India. But unfortunately, we have not any regulatory body till date. We can say a strong functionary regulatory body. Okay, when we discuss about MBBS, BDS, BMS, there are so many councils like Medical Council of India, Dental Council of India, Ayush Ministry, Pharmacy Council. There are respective councils are there. But at present in physiotherapy, there is no such separate council for physiotherapy profession. But in case of physiotherapy, recently on 28th March 2021, the National Commission for Allied and Healthcare Professional Act passed by the Government of India, but presently it's not in a fully functional stage. So before 2021, we have not any functional central agency like other professions. By the efforts of dedicated physiotherapy professionals, few state government had taken action in the formation of state physiotherapy councils like Delhi, Maharashtra, Gujarat, Chhattisgarh, Andhra Pradesh, Tamil Nadu, Haryana, and Jharkhand. Despite the establishment of these councils in various states of India, some state of India has paramedical council of physiotherapy professionals like Madhya Pradesh, Himachal Pradesh, Uttar Pradesh, Uttarakhand, Kerala, and West Bengal. But as we discussed earlier, we are separate from the paramedics by the different code, by the ISO international standards. But unfortunately, by the knowledge gap, you can say, from the bureaucrats, we have counted as a paramedics in few states. So this, all these things clearly show the inadequacy of law in the field related to the physiotherapy. There has been a negligence efforts by the government to the further the scope of physiotherapy in India. Lack of any significant legislation to the effect of controlling and enhancing the practice of physiotherapy and education in India has been proved to be a major setback to the growth of genuine physiotherapy practice in India. Inadequacy of such law regarding physiotherapy studies has been detrimental to both the science of physiotherapy as well as the promotion of public health in general. Framing of strict law, punishing fraudulent medical practitioners, and promoting the growth of genuine physiotherapy practice is the need of the hour in the national interest, and it's whole responsibility of the central government to initiate the process of formation of Central Physiotherapy Council as soon as possible to fulfill the request of Indian physiotherapy community and to save this beautiful science of wellness, because physiotherapy is not only a science of illness but it's a science of wellness also. There are present in present situation, there are so many associations who are regularly working in the direction of formation of a Central Physiotherapy Council. So some names are here on the screen. Now, the what is the difference between the association and the council? Association basically a body constituted by a same group of profession. We can registered anywhere in India. There are so many association at presently, you can see on my last slide. But the council is a quasi judiciary body constituted by the government. Councils have some rights, some powers. By the effects of those powers, we can the council can regulate the profession. A body of people elected or appointed or serve as an administrator, legislator, or advisor to make decision, to give advice on subject, to represent a particular group of people, or to turn or run a particular organization. It is a quasi judiciary body. It has some legal powers. Some existing councils are also there in few states. As I already told you, in Delhi, Maharashtra, Gujarat, Chhattisgarh, Andhra Pradesh, Tamil Nadu, Haryana, and Jharkhand. Jharkhand is the new one. The recent council is formed there. In case of structure of the state council, there have few members, elected members, nominated member, ex officio members, and some employees, registrar, assistant clerk, PN, etc., and the lawyers for the consultation. At present, on the basis of these elected nominated, because as we know, the more the elected number, the more power is in the council, the more the nominated member, the less power in the council. In Delhi, it's a partially nominated, some members are elected, some nominated. The president and vice president are elected, it's a good thing. In Maharashtra, again partially nominated, elected more, nominated less, again good thing, the president and vice president are elected. In Gujarat, partially nominated, elected less, nominated more. But good thing is that the president and vice president are elected. In Chhattisgarh, the fully autocratic, fully nominated president and vice president both are nominated. In Andhra Pradesh, partially nominated, but the elected are less, nominated are more. Good thing is that president and vice president are elected. In Tamil Nadu, autocratic, fully nominated, president and vice presidents are nominated. So it's not a good thing. And again in Haryana, the partially nominated, elected less, nominated more. But unfortunately, here president and vice president are nominated, and it's not a good thing. In Jharkhand, partially nominated, elected less, nominated more. But the good thing again, the president and vice president are elected. Where the elected members are more, the council have more power, more the functions of state councils, what the council exactly do. Because lots of people are confused between the association and councils. Association, as I already discussed, it's only group of people who have no power, only you can say joint family. But council have power to regulate the main functions of the council, to regulate physiotherapy education and practice. Because when the council is there, regulate the syllabus, it's regulate our whole the things we discussed, we study in our syllabus, give registration and maintain the register of recognized physiotherapists, so the people can easily differentiate recognized or X, to establish and maintain standard of physiotherapy education at all level, UG, PG, etc. As I already discussed, curriculum to be prescribed, to regulate practice of the registered professionals, protection of public also from the fraud and quacks, control over malpractice, because they, as we see in present scenario, there are lots of people are roaming here and there and say though they and them are physiotherapists. It's not a good thing, and it's all because of the lack of the certain rules and regulation, and the lacuna is just because of this council, absence of the council. The recommendation of the government to grant permission to start new college, new course, increase capacity in all course, to decide criteria for recognized qualification, to advise government in matter related to need of human resources in the field of physiotherapy, to assist the government in regard to continuing education of registered physiotherapists, to take legal action against bogus course, bogus person, and unregistered professional, to suspend or remove name of such registered member from register and prohibit them from practicing if found malpracticing. Council can send them behind the bars. To hear appeal against registered member and if found guilty, punish the member legally. To hear and decide on appeals against any decision of registrar of council. Why Central Physiotherapy Council is needed in India? Because India is a fast developing country of the world. Maximum number of physiotherapy institutes were offering diploma, degree courses. Non-uniformity in education across various states of India as well as in state like Haryana. ITI run PT technician course, and it's not a good thing. It's dilute the whole profession. For better future of professionals and students in the country, for easy differentiation of diploma holder or graduate in state and other parts of the country, better autonomy of physiotherapy profession in India, legal protection of the rights of physiotherapists in country, legal platforms for professional issues, hence better dignity and identity, representation of various government authorities, example pay commissions, planning commissions, UGC, NABH to create more jobs, easy to address political insensitivity because present situation there are lots of political leaders don't know about anything regarding physiotherapy and it's a big issue. But the in present situation, as I already discussed, the National Allied Healthcare Council Act has already passed. That's why in all the state allied and healthcare council should be formed as early as possible. Every state government shall, by the notification within a 6 month from the date of commencement of this act, constitute a state council to be called the State Allied and Healthcare Council for exercising such power and discharging such duties as may be laid down under this act. And good thing is that the definition of physiotherapy as per the new act in India is very much satisfactory. As per the definition of the new act, physiotherapy professional is a person who practice physiotherapy by undertaking comprehensive examination and appropriate investigation, provide treatment and advice to any person preparatory to or for the purpose or in connection with movement of functional dysfunction, malfunction, disorder, disability, healing and pain from trauma and disease using physical modalities, including exercise, mobilization, manipulation, electrical and thermal agents, and other electrotherapeutics for preventions, screening, diagnosis, treatment, health promotion, and fitness. The physiotherapist can practice independently. It's a good word, the practice independently as per new act or as a part of multidisciplinary team and has a minimum qualification of bachelor's degree. It's a good thing for us, but in the new allied council it's a fully nominated, so it's a autocratic, less power for us. The council within an umbrella body, not only for physiotherapists, it's for 56 different allied and healthcare professional categorized into 10 broad categories, and physiotherapy is one among them. It may be proving great or not, depend upon the time, because at present it's not fully functional, but no doubt definition of physiotherapy under this act is completely satisfactory. So less discussion, more action, and less conversation about change is the barrier. Actually committing to doing something and then acting is what is required, said by the David Jacks. And we are at a momentum stage in the history of India. By a common endeavor we can raise the country to the greatness. अगर हम सब लोग मिल के प्रयास करेंगे तो डेफिनेटली, जब हमारे पास इनिशियल लेवल पे कुछ भी नहीं था, नॉट इवन अ सिंगल काउंसिल, फ्यू स्टेट्स जो है उन्होंने एफर्ट्स किया, काउंसिल एस्टैब्लिश करने में मदद की, और आज उसी के इफेक्ट से कहें, उनके प्रयासों से कहें, आज नेशनल लेवल पे भी एक अम्ब्रेला ही सही लेकिन हमारे पास कुछ है, और इन फ्यूचर वी एक्सपेक्ट that the separate council is also may be there by the efforts of such dedicated professionals. Thank you with such words, and thank you all for giving
थैंक
me
यू
this
डॉक्टर मुदगिल।
opportunity.
ये ऐसा टॉपिक है जो इस समय बहुत ज़्यादा ज़रूरत है, क्योंकि बहुत सारे जो बडिंग फिजियोज हैं उनके मन में बहुत सारे डाउट्स रहते हैं कि हम पैरामेडिकल्स हैं या मेडिकल प्रोफेशन में आते हैं, और वो आपने बहुत बखूबी उस चीज़ को दूर किया कि हम पैरामेडिकल्स में नहीं आते हैं, हम एक मेडिकल का इंडिपेंडेंट पार्ट हैं मेडिकल प्रोफेशन का। और ये मैं आप सबको बताना चाहता हूं कि हरियाणा काउंसिल के पीछे इनका बहुत बड़ा हाथ है, और इनके जो सालों का संघर्ष है वो बहुत बड़ा रहा है हरियाणा काउंसिल को बनाने के पीछे। और इनके डेडिकेशन की मैं तारीफ करना चाहता हूं, क्योंकि इन्होंने सब कुछ छोड़ के भूखे प्यासे आंदोलन खूब किए, और वो मेरी आंखों के सामने मैंने देखा वो सब चीज़ें। और आज आपका समय बहुत ज़्यादा बिजी था, इस वजह से पर फिर भी मैं आपका शुक्रिया अदा करता हूं कि आप अपना टाइम निकाले और हमारी कॉन्फ्रेंस में आपने एक बहुत अच्छे टॉपिक पे बच्चों को एक नॉलेजेबल सेशन
सर
दिया।
सर मेरी 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 डॉक्टर साहब एक रिक्वेस्ट भी आपसे। हेलो।
हाँ जी।
मेरी रिक्वेस्ट है कि आप ये हमें एक ऐसा फिजिकल प्लेटफॉर्म भी प्रोवाइड करें, और डेफिनेटली हम एक्सपेक्ट करते हैं इन फ्यूचर आप हमारी जो ज्योति विद्यापीठ है कि इतना प्रीमियर हमारा इंस्टीट्यूट है और जिसको आप संभाल रहे हैं इतने अच्छे से फिजियोथेरेपी डिपार्टमेंट को, तो वहाँ एक फिजिकल कॉन्फ्रेंस ऑर्गेनाइज करें ताकि बच्चों से फिजिकल इंटरेक्शन भी हो पाए हमारा।
ये बिल्कुल प्लान में है डॉक्टर मुदगिल, और कुछ अलग और नया आपको मिलेगा। थोड़ा सा वेट करिए और पूरा ऐसा कुछ ऑर्गेनाइज किया जाएगा कि जो अब तक वर्ल्ड में कभी किसी ने नहीं किया होगा। एंड ये मेरा वादा है, विद इन 1 ईयर आपको फिजिकल प्लेटफॉर्म भी हम देंगे, और आपको जरूर आना है उसमें। जयपुर आपको इनवाइट करेंगे इसके लिए। एंड
Definitely, sir.
थैंक यू, रियली थैंक यू सो मच। एंड फॉर फर्दर सेशंस, ये फर्स्ट साइंटिफिक सेशंस का अब हम स्टूडेंट्स और स्कॉलर्स का हम स्टार्ट करते हैं, और इसको आगे बढ़ाएंगी डॉक्टर रेंसी कोसी। तो रेंसी कोसी, डॉक्टर रेंसी से मैं हाँ या अभी स्क्रीन पे आ गई हैं, तो प्लीज टेक ओवर द चार्ज। थैंक यू।
Thank you, sir. Namaste, everyone. I am JV Dr. Rensi Koshi. As proceeding with our next international conferences, we are starting with our starting with our scientific paper presentation. For this, I will invite Harshika Gupta to start with her presentation. Harshika, please unmute yourself and yes, Harshika, you can unmute yourself and you can switch on the camera and you can share your screen as well.
Okay.
Over to you, Harshika.
So I'm audible.
Yes, you are.
Should I start now?
Yes, you can share your screen and start.
I share my screen, share my PowerPoint presentation on the mail right now. Ma'am, should I share or you will share?
Harshika, if you can able to share your screen better, please share your screen and your slides.
Sir, actually in this site, there is no option for sharing the screen right now.
Because you might be you have log in with your mobile. I think so.
Yes, sir, I'm logging with my mobile as I'm at working place, so I don't have a laptop right now.
क्योंकि लॉगिन अगर मोबाइल से करोगे तो स्क्रीन शेयर नहीं हो पाएगा। लैपटॉप से अगर हो पाए तो प्लीज करो। और टेक्निकल टीम, अगर आप शेयर कर सकते हैं स्लाइड तो बताइए।
Yes, I already shared to the technical team my PowerPoint presentation.
Yes, we are sharing the screen.
Okay.
Harshka, if you have shared your screen, you can start with your presentation.
Okay, ma'am, sure. As it is not visible right now. Yeah, got it. Thank you, ma'am. First of all, from my bottom of heart, I want to wish and greet to all the dignitaries present over here and all the presenters. Myself, Harshika Gupta. Today, I'm here for the paper presentation with my title, Exploring the Potential of Motion Capture Technology in Physical Therapy, a review of current research and future direction. Ma'am, next slide, please. The next slide is my content about the presentation is content is like an introduction, background, the methodology, the exclusion inclusion criteria, and the conclusion and results with their references. Next slide, ma'am, please. Thank you, ma'am. Background. No, ma'am, introduction background slide. It's yeah. Background and introduction. Physiotherapy is a healthcare profession that aims to improve the maintain and restore the physical function in individual affected by injury, illness, or disability. Basically, we have a as a, physiotherapy is not in a current, not an emerging field. It's in a great field of one of the branch of the medical science, and it there has a traditional approach as well as the modern approaches as per the time will change, the technology will develop, and advancements of the techniques. So traditional physical therapy methods include the subjective and unrealistic manual assessment and therapies, whereas the motion capture technology provides a purpose and method for measuring and analyze motion patterns. Motion capture technology is widely used in the entertainment industry, such as movies and games, TV shows, and lot of things which are the young, especially the young youth, and the I think I can say every people was indulged into the technology. In recent years, has been used more and more in physical therapy as a diagnosis and therapeutic method. Motion capture technology has become a common place, or I can say common technique, which we were used by an every either the younger, elder, older, or the 1 year to the 7-year child are also using their phone for their entertainment purpose. Now, this article provides a comprehensive review of current literature on the use of mobility device in physical therapy, including in its use in mobility assessment, development, and enhancing the patient engagement. This article also discusses the benefits and limitations of using the technology in physical therapy, as well as the challenges of integrating technology into healthcare. Based on the literature review, these articles recommend future research in the field of stopping this device and physical therapy, as the people are depending too much, and we have a therapeutically use also. But in future, it's like pretend that some now we are exploring the technology, and after some few years we have to be also find that way of stopping these technologies, because it's a physically those there's a, apart from the therapeutic, those are very habitual for the technology. This meaning is only for that. Next slide, please, ma'am. Yeah. Now the aim and objective of the my this paper, why I choose this title, and why decided to write this paper. Just give me one moment, as there is some clutch, I think. Yeah, it's visible. To evaluate the potential of motion capture technology in physical therapy and exploring the advancement in physical therapy based on the technology. Basically, my aim is to enhance my skill, to enhance my knowledge regarding the development in the technology, especially in the physiotherapy field, and the other multidisciplinary approaches with the entertainment of the people, or I can say the clients who we are going to treat. So about the knowledge, get the knowledge, and of course to create a platform, to create a treatment protocol engagement of the patient and doing the better approach. We can say go for the patient center approach. So this is my objective. Next slide, please. Now the methodology. The methodology is I as being an author and my first author, my guide, we are doing this study by using the online search portals like including the portals named as PubMed, Science Direct, and Web of Science, was conducted to identify the relevant articles as related to my topics. The search term used were motion capture technology, physiotherapy, physical therapy, rehabilitation, assessment, and treatment. They are the keywords which are articles, and out of that, a total of 30 studies were included in the review on basis of my inclusion criteria and the exclusion criteria, which was published between the 2010 to 2022. Next slide, please. Ma'am, next slide, please. Yeah, this is the basically just a review, or I can say flow chart, or you can say the diagram, why by way of deciding the topic till implementation. Firstly, I choose the topic as the according the theme. After go and find out the available past literatures, or available in the online sources, or in a hard materials. After that, I screen and analyze, and after that we go for the strategic treatment protocol, as it's a review study, but in terms of application or implementation, or in a technique to apply the things in a future. So we have to be plan also the strategic treatment protocol, as we can't go just read and search the papers and make a review. It's a also think to it's applicable or not. So just for that treating them and go for the implementation. Now it's my inclusion exclusion criteria, as my inclusion criteria is advanced approaches, which is just determine or represent the motion capture technology, and the publication language is only the English. Other than are my exclusion criteria, and the publication is which is published in the authentic journal and documentation is my inclusion criteria. Whereas the motion capture technology is my only the inclusion criteria. Other than these technologies, like lot of technologies available in terms of modalities, in terms of technologies, like manual technologies also develop in the related with the correlate with the advanced technology. They are my exclusion criteria. Now this is the review of literature, where my 4 parent article, as shortage of time, I just mentioned the parent 4 articles, which is under the reference of my presentation. They are tell us that and as per methodology is already defined that all the resource or articles were available from the Web of Science, PubMed, Science Direct as well. And the studies title named as over the slides, and they concluded motion capture technology is very helpful in improving the reliability, the accuracy of the patient or the client, and helpful in the engagement of the patient, and make the improvement in a efficient time, and give the results in a that particular time, that it basically increase the patient's engagement, and including the good quality of life also. Uh, Definitely it will work on the psychological as well as physical concept of the client. Next slide, please. The results. The review has identified several benefits of using mobility devices in physical therapy. A key benefit is its ability to provide objective quantitative measurements of motion patterns. Motion capture technology can also provide real-time feedback to patients and as well as the therapists, which cloud lead to more efficient and effective treatments. Additionally, technology can be used to track change in movement pattern, like we are using a gait pattern to analyze the gait pattern, to analyze the posture, ergonomics, which can help in the monitoring progression report and adjust the treatment plan or progression report accordingly. However, the review also found some limitations of the techniques, such as high cost and need for the specialized training and equipments as well. Next slide, please. The next slide is my conclusion. Motion capture technology has become more common in physical therapy in recent years, providing therapists with with the new tools to evaluate and treat patients. This article provides a comprehensive review of current literature on the use of mobility device in physical therapy, including its use in mobility assessment, development, in the progression of the patient of the client. This article also discusses the benefits of limitations of using technology in physical therapy as well as the challenges of integrating technology into healthcare. Based on the literature review, this article recommends future research in the field of stopping device in physical therapy. As I already mentioned in my first slide, that it's a great impact in our therapeutic treatment. But apart from this, it is more habitual in the upcoming youth or the generation. Next slide, please. They all are my references which I use in my presentation. Before I stop or I sharing my thoughts, I just want to give my humble gratitude to the Ankit Bhagav sir and the whole JVU team to create this platform and give us chance, because this is my first presentation after my completing the graduation, and I'm eagerly waiting for this platform as it's a great chance to enhance the skills as well as learn more, because this is the only chance, I think, being a student professional, that we can go in a that way we can get the input as well as we can explore the profession in a completely official platform with the get the indeed the insights from the immense speakers and judges. So thank you so much. I literally very feeling blessed and excited to learn more in future from all of the dignitaries.
Okay, thank you, Harshika. Guys, continuing with our session. Next, I am calling Dashpreet Kaur.
Good morning,
Yes,
ma'am.
good morning. Yes, you can share your screen.
Is my slides visible?
No, it's not.
Is my slides visible now, ma'am?
No, it's not visible.
I'll stop sharing. Oops. Screen share. Ma'am, is it visible now?
No, it's not visible.
It's showing StreamYard.com is sharing a window. It's not
Okay.
visible.
No, it's not visible now.
I'll stop sharing again.
Select your screen and just you can click on the center and
Yeah, I just did that. Not yet, ma'am.
no, I'm sorry.
Oops. Now, ma'am?
Yes, it is.
Okay, thank God. May I start, ma'am?
Please.
Yeah, good morning, everyone. At the onset, I would like to thank the organizer for giving us this opportunity to present our research work. And without taking much time. So, my topic is physiotherapeutic treatment of idiopathic facial nerve palsy as guided by qualitative and quantitative evaluation of facial nerve. So basically, if we see, Bell's palsy is one of the most common form of acute, spontaneous, peripheral facial paralysis. And during the COVID time, we saw there was an increasing number of cases of facial palsy, and that too of idiopathic origin. And if we move on to the treatment options, we usually have medicines, usually the role of corticosteroids and antivirals, to physiotherapy. And in physiotherapy, electrical stimulation is one of the most commonly recommended modality. However, there have been a lot of studies which show the negative effect of electrical stimulation as it increases the aberrant reinnervation and synkinesis. Synkinesis is one of the most unwanted sequel in the facial palsy due to aberrant regeneration. And very surprisingly, during these COVID waves and thereafter also in the last year, we saw certain cases in which the patients at the acute onset presentation stage were mimicking oculo-oral pattern of synkinesis. So basically, synkinesis, though it occurs in the repairing phase, but we had mimicking presentation in the acute phase also, which forced us to think about different methods of evaluating our patient and then deciding upon the physiotherapeutic modality. So we tried to address this problem by using degenerative index as our therapeutic guide. So the need of this study was that since the clinicians are divided in their opinion regarding whether electrical stimulation should be used or should not be used, so there was a need to find a suitable scenario when which kind of modality of physiotherapy we can use. So the aims and objective was to study the extent of nerve damage, number one, and on the basis of the nerve damage, provide physiotherapeutic treatment. And to find out the extent of nerve damage, we use the qualitative and the quantitative test. And through the quantitative test, we use degenerative index. So degenerative index is basically electroneurographic quotient of the affected side divided by unaffected side. So we get certain percentage values which help us to understand whether there is an axon loss or no axon loss, mild, moderate, severe, or extreme. So on the basis of that, we started providing the therapy. So material and method: 14 patients with acute onset of Bell's palsy with no other identifiable cause of facial palsy and recommended by neurophysician to the Department of Physiotherapy were included. Their clinical data, including demographics and other comorbid conditions, were also noted down, and they all underwent qualitative and quantitative assessments. So, again, facial paralysis less than 30 days of duration, age from 10 years to 59 years, and no history of recurrent idiopathic facial palsy. For assessment, we did all the videographic evaluation. Then we used House-Brackman facial grading scale and Sunnybrook facial grading scale. These two scales have been shown to be very sensitive and specific in finding out the amount of facial nerve damage in the cases of idiopathic facial palsies. And then we used our nerve conduction studies, which was repeated after every 21 days or till complete recovery. And we also did 3T MRI, 3 Tesla MRI, along with the constructive interference in steady state CIS protocol for the facial nerve to find out whether there is any lesion anywhere in the pathway of the nerve. So these are our 14 patients on which we have performed this study so far. So if we see their clinical data and other parameters, like the time of presentation of the patients was roughly within first 10 days, and mostly they are male patients. We had only 3 female patients, and on House-Brackman and Sunnybrook, they had different grading system. Grade 6 shows the most severe form, and the Sunnybrook is out of 100. The scores out of 100, which tell us the amount of damage in them. The most important parameter here was the electroneurographic index, where we found out how much the nerve is damaged in the frontal branch or the nasal branch or the mentalis branch. So we used basically 3 primary branches in these patients. And what we found that 92% recovery happened in 45 days, and these percentage came basically on the repeat NCS, how much damage was left. So in 45 days, 92% recovery, 88% recovery in 37 days. And so we have different timeline for these patients. So now the target is to have their repeat repeat nerve conduction studies at the end of 6 months, so that we are able to find out whether any kind of synkinesis or hemifacial spasm or any other complication has arisen, and electroneurographically, that means qualitatively, how much the recovery has taken place. So as the study is an ongoing study, we have some emerging conclusion that screening of the patient by calculating degenerative index can serve as an important guide in deciding the rehab protocol. Indiscriminate use of electrical stimulation has to be stopped because it increases the chances of synkinesis, and also the clinical presentation of the patient which indicate excessive motor outflow. What we have to understand, facial muscles are quite different from other skeletal muscles because these are flat muscles and they work in unison. They have their synkinetic pairs within themselves, which leads to more combination of movements if they are not managed properly. So along with qualitative measures, quantitative measurements also need to be done, and however large sample studies are warranted. Thank you so much.
Nice presentation, Dasprit. I must say you have a very good topic in PhD, and I hope you will come out with a new way of treatment, and definitely you will do it. I am really proud of you. Thank you.
Thank you, sir. All your blessings, sir. Thank you.
Thank you, Dashpreet, for your nice session. Next, I am calling upon Mansi Joshi from the BPD fourth year.
Namaste, I JVN Mansi Joshi, BPD 4th year student from the Department of Physiotherapy and Diagnostics. I am present here to present on my topic Mackenzie exercises in the treatment of neck pain in women. So, our neck is made up of 7 vertebrae that extend from the base of our skull to the upper torso region. Now, in addition to these vertebrae, there are many soft tissue structures like muscles, ligament, and cervical disc. These all are connected in a unit to make our this cervical vertebra. Any abnormalities, inflammation, or injury in all these associated structure can cause neck pain or stiffness. Now, sometimes neck pain is secondary to the stiffness, and sometimes stiffness is secondary to the pain. Common sign and symptom associated with this neck pain are: the main symptom is neck pain. Now, pain can be localized, or pain can also be like radiating to your upper extremity or upper thoracic region. Now, in addition to pain, there are limited range of motion, stiffness, headache, brachialgia, and dizziness. What is Mackenzie exercises? Mackenzie exercises is an exercise protocol given by Sir Robin Anthony Mackenzie in the 1950s, which get popularized around 1985. So first, Mackenzie give a protocol for the treatment of low back pain. After getting positive feedback from all the patients of low back pain, he appeared by giving another exercise protocol for the treatment of neck pain. So he first described neck pain in the three syndromes, that are postural dysfunction and dearrangement. Postural syndrome is the result of any type of postural defect, for example, awkward sleeping posture, awkward standing and sitting posture, or slouch posture. Dysfunction syndrome is mainly caused by adaptive shortening of the structures that may be because of the poor posture. Dearrangement syndrome is the result of the change in the position of the invertebral disc that can result in the change in the position of the vertebra that are above and below the level of that disc. Now, Mackenzie basic protocol. So Mackenzie gives a 4-week protocol for the treatment of the patient with neck pain. But he makes sure that the before starting of the treatment, we all have to follow a basic protocol that is based on the neck retraction exercises of the neck. Now, in this exercise, the patient is instructed to retract his head as far as the possible to its end range. Now, it can be performed in two ways, static and dynamic. In static exercise, the patient has to hold in the end range position for 1 to 2 minutes and then he will come to the neutral position. But in the dynamic form of exercise, he will rhythmically move the movements in the form of the repetitions of 4 sets with 15 to 10 repetitions with 1 to 2 minutes of rest given between each set. Now, first week exercise protocol given by Mackenzie. In this exercise, patient is subjected in the supine lying position with his chin tucked. Now, patient is asked to retract his head and push his head on the couch such that his head is applying pressure over the couch. Now, end position is maintained for 1 to 2 seconds. Then patient will the patient will come back in neutral position. Now this whole exercise should be done in 4 sets of 10 to 15 repetitions with 1 to 3 minutes of rest given between each set. Now second week. Now, second week exercise is the progression of the first week exercise. In this exercise, patient is in sitting position and patient is asked to retract his head to the end range, but extension movement is added in this exercise. But the main thing to be keep in mind while doing this exercise is that both the movements should be appear as a single movement. There should not be any time lag between these two movements when they are performed. So this exercise should be done in 4 sets with 1 to 2 minute rest between each set. Now third week exercise protocol. So third week exercise protocol is basically performed by therapist on the patient. In this, patient is positioned in a supine lying position with his head out of the couch. Now therapist support his head by putting his one hand on the occiput and other hand on the chin. Now, now therapist passively will retract his head and will perform his upper cervical extension with a slight traction given by the therapist while doing this whole exercise. Now, the traction and extension should be maintained throughout the range of motion on the whole maneuver. Fourth week exercise. Now, fourth week exercise is basically a progression of all these exercises, and all the combined movements of neck are being performed at the same time in this exercise. Patient is in supine sitting position. Now, therapist will passively retract the patient head with slight lateral flexion of the neck, and then will rotate the neck in the direction opposite to the retracted part, and will finally a combination of retraction and neck flexion with the overpressure will be applied by the therapist on the patient. This exercise should also be done in the 4 sets with 10 to 15 repetition in each set with 1 to 2 minutes of rest given between each set. Now these are some additional exercise that is given by Mackenzie to be performed in addition to these weekly protocol. First is basically the neck retraction exercise. Now, in all these exercises, if patient is unable to perform the retraction by its own, then he can apply overpressure by his own, or also therapist can also help her to apply overpressure passively. Now, first is neck retraction exercise, or we can also say chin tuck. Second is neck extension exercise. Third is neck lateral flexion. Fourth is neck side rotation. Fifth is neck extension with applying over pressure by the patient itself. And sixth is neck extension with slight neck rotation. Conclusion. Now, Mackenzie exercise has been found to be very effective in treatment of patient with neck pain, and 90% of the patient has shared positive feedback for the treatment when they follow Mackenzie exercise protocol. Thank you.
Thank you, Mansi. Next, I am calling upon Shalu Rani.
Shalu, please open your cam.
Good morning, sir. Good morning, ma'am. Good morning to all respected judges, my teacher, and my dear friends. Is PPT visible? Hello, ma'am. Is it visible?
No, still not visible. On present option, just click on the entire screen.
Sir, is it visible?
No, it's not.
शालू स्क्रीन नहीं हो रहा है क्या शेयर?
No, sir. यहाँ से तो शेयर हो रहा है सर, पता नहीं क्यों शो नहीं हो रहा प्रेजेंट.
इसको बंद करके दोबारा शेयर करो.
सर एक सेकंड, आई विल ट्राई. आई थिंक अब हो जाना चाहिए सर. नाउ सर, इज इट विजिबल?
अभी तक तो नहीं. देखते हैं, थोड़ा फ्यू सेकंड्स का लैग हो सकता है नेटवर्क की वजह से. तो
मे बी सर.
हाँ, अब एक मिनट. हाँ, ठीक है, अब दिख रहा है.
Is it visible, sir?
Yes, yes, now it's visible.
May I start, sir?
Yes, you can start.
Okay. Good morning to all of you. The topic of my presentation is the factor which are responsible for the patellofemoral pain syndrome. We will start with the what does mean by patellofemoral pain syndrome. Patellofemoral pain syndrome is usually defined as the pain around the patella that occurred during or after the high loaded knee flexion and extension and accompanied by impaired function of the knee joint. The patient mainly complain the pain anterior or retropatellar region without any other pathology. It is known as patellofemoral pain syndrome. The anatomy of the joint is it is a articulation between the patella and the femoral. The patellofemoral joint is a diarthroidal plane joint that consists of the posterior surface of the patella and the trochlear surface of the distal anterior femur. The prevalence of the patellofemoral pain syndrome, it is more common in the women. Women experience an increased prevalence of patellofemoral pain syndrome when compared to the male. The prevalence has been reported as high 1.5 times greater in the female as compared to the male. The patellofemoral pain syndrome is one of the most common form of knee pain in adults under the age of 40 years, with an estimate prevalence 23% in the general population. In today's scenario, all the knee pain we cover under the osteoarthritis knee, but it is not like that. The each and every knee pain is osteoarthritis. It may be other condition if like the patellofemoral pain syndrome. The objective of this review is the purpose of this review is to assess the factor which are responsible for patellofemoral pain syndrome and that affect the joint function. The stability of the joint, the mainly stability of the patellofemoral joint is mainly depend upon the biomechanics and the dynamic and the static soft tissue structure which are attached to the patella. Due to shallow and incongruent fit between the patella and the trochlea, the stability of the patellofemoral mainly depend upon the static dynamic soft tissue structure that medially and the laterally attached to the patella. The stability is provided by the condyle of the femoral condyle, and the dynamic and the static soft tissue. Now we will discuss the factors which are responsible for the patellofemoral pain syndrome. It is a chronic disease. It is caused by the overuse and misuse of the muscles, and rather than acute trauma or broadly classified into the two categories. First one is the patellar malalignment and the second one is the patellar maltracking. In this presentation, we will focus on the patellar maltracking. Patellar malalignment, if there is some biomechanical malalignment by birth occur, that is under the patellar malalignment. But patellar maltracking, there is an alteration in the patella. Mainly, we will focus on the lateral patellar tracking. The factor which are responsible for the lateral patellar tracking is the first one is the muscular imbalance or overuse, as we will discuss under these the weakness of the quadriceps muscle, mainly the vastus medialis oblique, weakness of the hip abductor and the external rotator. Next, the hamstring, quadriceps, calf muscle, mainly soleus and the gastrocnemius, and the IT band, or we can say the tensor fascia lata. And it may occur due to the overfoot pronation and may due to the increased internal rotation of the tibia with the increased valgus stress and the excessive lateral tracking of the patella. How does it affect the weakness of the quadriceps and the weakness of the hip abductor and the external rotator, and the further how it will lead to the lateral tracking of the patella? We will discuss one by one in this table. First, the weakness of the quadriceps muscle VMO. As some studies shows that in the patellofemoral pain syndrome patient, the electrical activity in the vastus medialis oblique VMO is decreased as compared to the vastus lateralis muscles. It ultimate the mainly component which provide the medial stability to the patella. It is the vastus medialis oblique. When there is a weakness of the vastus medialis, vastus lateralis more activate and it pull the patella laterally and ultimately to the patellar maltracking and put the compress or excess load on the patellofemoral joint and ultimately lead to the patellofemoral pain syndrome. And the second one is the weakness of the hip abductor and the external rotators, the mainly the gluteus medius muscle which stabilize the pelvis during the movement, and the gluteus medius muscle is mainly eccentrically control the tibial internal femur internal rotation and the adduction. If there is a weakness of the gluteus medius muscle, it will lead to the tibial internal rotation and the femur internal rotation, ultimately increase the quadriceps angle, and which lead to increase the stress on the patellofemoral joint and ultimately lead to the patellofemoral pain syndrome. And the next is the tightness of the quadriceps. If there is a limited flexibility, or you can say the tightness of the quadriceps may pull the patella superiorly and increase the compression on the patellofemoral joint during the physical activity. activity in the flexion and the extension of the knee joint. The next one is the tightness of the hamstring muscle. Uh, there is a limited hamstring flexibility. There is a two particular during the flexion, the extension, the muscle should be in the particular length. During the extension at the knee joint, the hamstring, if the hamstring muscle is tight, it will decrease the extension at the knee joint due to the tightness of the hamstring muscle. Ultimately, it will increase the quadriceps force production, and which restraint offered by the hamstring cause the slight knee flexion during the physical activities, and ultimately increase the stress on the patellofemoral joint. The next is tightness of the calf muscle, meaning the gastrocnemius and soleus. If there is a tightness of the calf muscle, it will decrease the action during the gait, which may result in excessive subtalar joint formation, medial internal rotation. Gait to clear the ground to gain additional range of motion for the terminal stance phase. Excessive gait will do excessive tibial internal rotation and excessive tibial.
I think she got disconnected. We wait for 1 or 2 minutes.
She is connecting again. Just wait for 2 minutes. I think there must be a network issue. Renzi, please proceed with the next presentation.
Okay, sir.
Okay, she got connected. Yeah, fine.
Hello.
Yeah, Shalu, please share your screen.
Uh, Sorry, sir. I think some network issue is there.
If your presentation is about to end, then no problem. Yeah, now it's coming. Yeah, it's yeah. You
Sir,
can.
it is
It's
visible.
visible. You can start. Yes, yes. You can start.
Sir, starting से start करूँ? Should I start with the initial?
जहाँ छोड़ा था लास्ट वहां से स्टार्ट करो.
सर मुझे नहीं पता कहाँ था, मेरे हिसाब से तो मैंने पूरा कंप्लीट कर दिया.
Oh, no, anyways, go over factors only you were there. So just complete that 2 slides and complete this. Okay.
I think I should cover this table, sir. I'm audible. Hello, sir. I'm
Yeah,
audible.
yeah. This it's already done. Go ahead. Next slide.
This is the last slide in which we discuss the
It was
the
last. Okay.
ultimate.
Yeah, then it's completed. Yeah. Thank you. Thank you.
Yes, sir.
Thank you, Shalu. Nancy, please proceed with the next presentation.
Thank you, sir.
Thank
Thank
you,
you, ma'am.
Shalu.
Thanks to all of you.
Next, I will call upon Ayushi Gupta, student of BPT 4th year.
Namaste, myself Jevina Aishi Gupta from the Department of Faculty of Physiotherapy and Diagnostic. Today I am going to represent a presentation on the topic antenatal care during pregnancy. Antenatal care. Antenatal care is a type of preventive health care. So antenatal care, it is a care plan or excessive program which is given during the period of pregnancy to improve the overall health and lifestyles. Uh, Pregnant women which helps in a healthy and natural birth or labor. Antenatal exercises during pregnancy or before delivery of the baby are called antenatal exercises. Physical exercises performed by the expectant mother to bring out optimal functioning of all system and prevent complication are antenatal exercises. Advantage of antenatal exercises: reduce morning sickness, reduce insomnia, anxiety, and stress, reduce other pregnancy related complications, example fatigue like cramps, edema, or extremities, prevents excessive weight gain during pregnancy, improve muscle strength, improve core stability, maintain muscle length and flexibility, improve glycemic control, improve posture, enhance relaxation, prepares for physical demands of labor. Types of antenatal exercises. Yoga. Yoga is considered one of the safest forms of exercise that can be performed antenatally to relief to back pain, rib pain, hip and joint pain that is commonly experienced during pregnancy. Next, aerobics. Aerobics, low impact aerobics have to perform during pregnancy, help in strengthening the lungs and maintain balance and muscle to reduce the stress. Example, cycling, swimming, running, jogging. Pelvic floor exercises. The pelvic floor exercises also for Kegel are suitable for strengthening the pelvic function. Example, pelvic trek, breathing, pillow squeeze. Breathing exercises. Abdominal breathing. Exercise can relieve mild pain during labor. Lower costal breathing. Exercise can relieve medium pain during labor. Apical breathing exercise is suitable during labor with severe pain. Reference. This is reference. Thank you.
Thank you, Ayushi.
Thank you, Ayushi. As continuing with our first session of the day, I will invite Sonu Punia to continue with the paper presentation. Over to you, Sonu.
Good morning to all of you. Good morning, Professor Ankit Bhargav and ma'am. Sir, let's start with the presentation.
Yes, please start. Because just share the screen first.
Okay, sir.
Then you can start.
Sir, is it visible? My screen is
अभी नहीं,
visible?
कुछ शायद थोड़ा सा नेटवर्क लैग है, तो इस वजह से एक बार थोड़ा सा कुछ, हाँ अब आया है. हाँ, you can start
Okay.
now.
Yes, sir. Okay, my topic is the role of physiotherapy in women's health during pregnancy. Uh, Physiotherapy can make a great difference by providing information for pregnant women regarding evidence-based exercise protocol and rehabilitation during the pregnancy and postpartum period. Uh, um, Although physiotherapists are facing issue that is pertaining to the care of pregnant women, no specific guidelines are found regarding best practice for physiotherapists in this area. In this area, how is the intensity and what is amount of duration and what is the type of exercise and at where it is started, it started in a first trimester or second trimester. There is a no specific guideline. So physical activity and exercise in pregnancy that are associated with minimal risk, is it a true? It is not a myth. Although some modification to exercise routine may be necessary because of normal anatomic and physiological changes, and there are some fetal requirement. In the absence of obstetric or medical complications or contraindication, physical activity in pregnancy is safe, desirable, and pregnant women should be encouraged to continue or to initiate safe physical activities. And obstetrician, gynecologist, and other obstetric care provider that should evaluate women with medical or obstetric complication is any there carefully before making recommendation on physical activity participation during the pregnancy. There are certain problem that is associated with the pregnancy. First, most common that is a low back pain, and that is recently published article Weiss et al. That demonstrated that 76% of women experience pregnancy-related back pain, sciatica. There is a radiculopathy in the lower limb, and the prevalence of site-specific pain increases with the increased gestation period. And there are urinary and fecal incontinence. Urinary incontinence that is related to the stress. Pelvic floor dysfunction is there. Hyperthyroidism. There is a gestational diabetes may occur, and obesity related elements like back pain or knee pain that causes because of weight gain during the pregnancy, and frequent urination due to stress by the urinary bladder, loss of bladder bowel control when laughing or sneezing. There is a weakened core strength. Anxiety related issues are during the pregnancy. Pelvic organ prolapse may be there because of the stress that caused by the uterus, and the pregnancy induced hypertension that is a complications may occur during, and it is called eclampsia or toxemia of pregnancy. And there may be intrauterine growth retardation if uh, fetus is not gaining nutrient throughout the pregnancy. And problem that associated with postpartum period, physiotherapists should seek to prevent or evaluate deven thrombosis. It improve the physiotherapy that improve the respiratory, cardiac, git, locomotor, postural, and urinary functions, and encourage the bond between mother and newborn. And there is a perineal pain that may be associated due to perineal trauma, or maybe due to c-section surgery after delivery. There are certain guidelines for exercise during the pregnancy. Moderate intensity exercise that are likely to be the most common recommendation. However, the lifestyle before pregnancy should be considered to prescribe the type intensity. Is it sedentary? If a person is a woman that is athlete, or any other exercise is was practiced by the patient. And it depends on moderate intensity exercise protocol, and that should depend on the exercise perceived exertion that should remain between 13 and 14, slightly tiring. And the talk test may be performed, that is to speak and exercise at the same time. So if a patient is able to do speak and exercise at the same time, and perceive exertion that remain in between 13 and 14, that it should be recommended. And the duration of the exercise during and after pregnancy, these parameters should be evaluated. Women should be advised to remain well hydrated, avoid long periods of supine posturing during the exercise, and termination of the exercise if they have any warning signs like vaginal bleeding during the exercise, abdominal pain occurs suddenly, regular painful contractions if there is a problem, amniotic fluid leakage, dyspnea before exertion, dizziness, headache if their chest pain, muscle weakness affecting balance, calf pain or swelling. Physiotherapy should evaluate the safety condition of the home environment. If it is exercise is not supervised, guiding necessary adaptation of the environment to improve the quality of session. So, rehabilitation can be initiated in the immediate postpartum period through the guidance and kinesiotherapy. What is the posture and what are the mechanics during the exercise, involving various muscle group, including the pelvic floor. That is a very important part of antenatal or postnatal physiotherapy rehabilitation. Abdominal muscle strengthening exercise have been indicated for treating rectus abdominal muscle diastasis. Aerobic exercise in breastfeeding women improves maternal cardiovascular conditioning without affecting milk production, milk composition or infant growth, and it is usually initiated approximately 40 days after the delivery through the desire, availability of the patient, obstetrical clinical condition, and through a physical therapy evaluation. Women who are breastfeeding should consider feeding their babies or milking before exercising to avoid the discomfort of the engorged breast. What are the characteristics of a safe and effective exercise regime in a pregnancy? That is, it start from the trimester 12 week of gestation after evaluating well thorough examination, and duration of session may be 30 to 60 minutes, times per week at least 3 to 4 session, and it may be up to daily if a patient is not suffering from any dyspnea or any other warning sign. Intensity of exercise that less than 60 to 80% of the age predicted maximum maternal heart rate, that is should be calculated before starting the exercise. Environment, that is thermo neutral or controlled condition, air conditioning, avoiding prolonged exposure to the heat. सेल्फ रिपोर्टेड इंटेंसिटी ऑफ एक्सरसाइज बोग स्केल पे हम चेक करेंगे मॉडरेट इंटेंसिटी एंड इट शुड रिमेन बिटवीन द 12 to 14 on box scale, and supervision of exercise preferred if available, and if there is no supervision of exercise is present or available, then should follow the following guidelines that characteristic जो है अभी मैंने आपको बताए exercise के, and when to end until delivery, usually not exceeding 140 beats per minute. So other जो है they are generally speaking at least 150 to 300 minutes per week of moderate intensity aerobic activity is recommended if other exercise is not done by the patient. This activity should be sensibly distributed throughout the week. Evaluation, prescription, and supervision of the exercise should be told or prescribed or to the patient. And there should be general rhythmic activities to warm up. And after the exercise, after the session is over, then advise patient to do cool down activities before going normal activities. Benefits of the exercise in the pregnancy, it result in the higher incidence of vaginal delivery, and there is a lower incidence of excessive gestational weight gain, gestational diabetes mellitus, gestational hypertensive disorder, preterm birth, cesarean birth, lower birth weight defined as a gestational hypertension or preeclampsia. These are the benefits of the exercise. Now Dr. Varun continue for the next treatment part.
Camera start. Camera start. Good morning to everyone. Now, first we will discuss about the goals and the plan of care in prenatal phase. Goals: the physiotherapist will prescribe exercises to the patient that improve the posture and correct the body mechanics, upper and lower extremities to improve the strength of muscles, as well as to improve the abdominal muscle strengthening, as and giving some relaxation techniques, plan of care, training and strengthening of postural muscles, teaching correct body mechanics in all routine activities, strengthening the exercises of upper and lower limbs. Then comes to the type of exercises. 75% of women undergoing chiropractic manipulation restore significant pain reduction after manipulation. Clinically, it was found that helped to decrease the disability. High velocity, low amplitude thrust to the spine or pelvic joint produces significant improvement. Spinal manipulation of pregnant women in their second trimester increases uh, their functional outcome, as well as also help to relax the pelvic floor muscles. Walking, stationary cycling, aerobic exercises, dancing, resistance exercises by using therabands, elastic bands, uh, as well as free weights, stretching exercises, postural exercises, pelvic motion training and strengthening. All these can be helpful for a person. Here we can see that partial squatting on wall, as well as in second picture we see the individual is doing butterfly exercises to relax adductors, hip adductors, and breathing exercises to strengthen core muscles, lumbar stabilization exercises. Basically, by using TheraBand as per the patient requirement, as per the patient's body strength, muscle strength, we can choose different kind of TheraBands that also indicates their resistance. We are starting from low and then progress to medium and high resistance. In first picture here we can see the shoulder shrugging, and second for shoulder strengthening, scapular stabilization, as well as to strengthen elbow flexors. Here the patient is doing exercise to strengthen external rotators of hip. In this picture, the patient is doing exercise with the help of therapeutic ball, gymnastic ball, as well as stretching of the lower limbs. Here, stretching of scalene, pelvic tilt exercises, leg sliding exercises, and then comes to the pelvic floor exercise, that is Kegel exercises. That is very important part of rehabilitation, or you can say physiotherapy exercises during the pregnancy. This can help the patient to control the incontinence of bladder, that also termed as leaky bladder, as well as it decreases the prolapse. And the patient is asked to tighten the pelvic floor muscles as to attempting to stop the urine and hold it for 3 to 5 seconds. And patient can do it in any position in which she feels comfortable. Then relaxation and breathing exercises, diaphragmatic breathing, deep breathing exercises induces relaxation, as well as we can also use Jacobson method to produce relaxation. Jogging, running, uh, on an average 15 minutes daily walk or jog can be recommended to the individual. Swimming is also beneficial in pregnancy. Yoga and stretching, light resistance exercises. We always instruct the patient, do not overexert your body, do the exercises within your limits. As well as in postnatal exercises, we teach the patient to do breathing exercise, leg exercises, pelvic tilt exercises, foot ankle leg exercises in crook lying position, and pelvic tilting exercises. And we also teach how to handle the baby, how to bend forward, how to feed the baby to prevent the musculoskeletal problems like back pain, neck pain, shoulder pain. And after cesarean delivery, the patient also having a number of problems or associated complications like pneumonia, post-surgical pain, adhesion formation at incision site, vascular complication, faulty posture, pelvic floor dysfunction, abdominal weakness. And among these, additions of scar is highly negligible part during rehabilitation. So being as a physiotherapist, we must focus on the scar rehabilitation. Otherwise, after a lot of exercise, medicines, patient still complaining, having pain, but there is no solution. But if we give him proper scar rehabilitation, then patient gives very good recovery within a specific time period, because we know that if scar rehabilitation is not done, then there is a reduced mobility that will cause facial dysfunction and also leads to pain and disability. The exercises after cesarean section: ankle pump movement, pelvic floor exercises, abdominal exercises, deep breathing exercises, coughing and huffing exercise to relieve intestinal gastric pain, scar mobilization as we discussed. We teach the patient how to get into the bed and how to come out of the bed, and how to care the baby, how to take and how to feed him, and giving the light resistance weight exercises. That's all. Thank you.
Thank you so much for this wonderful presentation. Further
थैंक यू सो मच
moving
सर.
towards.
मैं डॉक्टर अंकित
Thank you.
भार्गव सर का बहुत बहुत धन्यवाद करना चाहता हूं. उन्होंने हमको इस प्लेटफॉर्म पे जुड़ने का मौका दिया, और ये टेक्नोलॉजी को यूज करते हुए मैक्सिमम कैंडिडेट्स जो है वो इससे बेनिफिट ले सकते हैं. और सर, आपका जो विजन है फिजियोथेरेपी को आगे लेके जाने का, सभी स्टूडेंट्स के ऊपर फोकस करने का, रिसर्च के ऊपर, एंड आई थिंक यू आर द only candidate among India who done double PhD, and that is also indicates your dedication for continuous research work and upliftment of profession. Thank you so much, sir.
Thank you, Varun, for this kind words. Now we are moving forward. We have a next speaker with us, and Dr. Mukesh Jain. And I warm welcome you, sir. He is a senior radiographer at SMS Medical College, and I really thankful to you, sir, to find out time for us on a very short notice. And thank you so much. I really welcome you, warm welcome. Thank you.
Okay. Am I audible, sir?
Yes, sir, you are audible.
And my screen is visible or not? I don't know.
Still not, but you can share it. Maybe because of the time lag, it will take some few minutes. So on present button, you can click on the entire screen. There is a present button. Click on that, and then click on the entire screen.
Yeah, but the present button is not visible to me actually.
Sir, you have login with the mobile or laptop?
It's tablet.
I think so. Okay. Uh, is it possible for
Okay,
you to present your topic like this? If it is not get shared, so you can
okay,
present it like that.
okay. Or
Because from system, if you log in, it will be easy for you.
yeah, I did it also.
Yes, sir.
Is it now visible?
Sharing screen is still not came up.
Okay,
Just just wait for few seconds. I believe there is a time lag, so because of that.
might be.
I think it's not shared, sir. No, it's not shared, sir.
I think it's not working. Maybe later on we'll see the screen, but we'll start. Thank you, sir, for inviting me for a chat academic extravaganza, and going to discuss about the emerging trends in the radiation technology, what we are now today, and where from we started. So, am I audible clearly, sir?
Yes, sir. Yes, sir. We can hear
Okay,
you.
okay. So nice. So just the emerging trends in radiology, how we start. So the radiology just after the inception of in 1895 undergoes a tremendous changes into it. Initially, the radiology is based on the medicines based on the symptoms, that how we escalate, how we palpate, and how we able to define the symptoms. Then we'll able to find the diagnosis of it. And these diagnoses only depends on the physical examinations. We don't have any kind of tool to see into the body. Radiology or radiation technology gives us the way to look into the body and tremendously change the medical field, right from open and see to see and open. Initially in surgeries, we firstly open the human body and try to find out the disease and try to cure it. But right after the inception of the radiation technology, we'll see that we turn towards the from open and see to see and open. So with the help of these technology, now we able to see what's inside the body, and if it is necessary, we'll go for opening or if it. So right from the beginning of the X-rays, it undergoes many changes. We witness the many of modalities, right from the X-ray machine to the sonography machines to CT scans, MRIs, gamma camera, PET CT, computed radiography and digital radiographies, digital subsection angiographies, DSAs, PEC systems, and many more. So we'll see that kind of changes. So it's many much transformations took place from 1900 to 2019. Right from we moved from the analog imaging to the digital imaging. Initially, we took the X-rays in the form of the films, started in the glass films, now switch to the digital imaging, undergoes a different transformations of different ages, right from the conventional imaging to the computerized imaging, and right now the digital imaging. And we see many of modalities um, encompassing the digital imaging. The technology changes also took place in the image processing also. We witnessed initially the image processing based on the conventional imaging in the darkroom imaging, that's known as the darkroom imaging, in which we tend to use the different chemicals and wet chemistries to convert the invisible image into the visible image. So we'll use different kind of materials and chemicals for it. Now it's transformed to the digital imaging in form of the daylight printers and in form of the digital printers. So we all witnessed that tremendous changes right from the darkroom chemistry to the digital chemistry. Also, these kind of changes took place in the film display system. Initially, we used the view boxes and the general lights to display the X-ray images. Now it turns towards the digital imaging. We have the medical grade monitors to display the images. We have the high resolution images, and we have the capability to deploy that high resolution images onto the monitors. Similarly, the conventional which witnessed the changes from the conventional fluoroscopy to the digital fluoroscopy. Initially, the fluoroscopy based on the direct live view. Now we witness, and that incurred many high amount of radiation doses in it, because the radiologist tends to see right from their naked eyes to the images, and it involved many kind of high amount of radiation doses. Now the digital imaging and the inception of the IITVs, image intensifier TVs, to prove the way and to help on the monitors. Then we'll see the advancement in the mobile DR and the mobile radiography systems. Initially, the radiography systems, mobile radiography systems based on the X-ray machines and the cassettes, we need to develop in the different places. We need to carry the cassettes right from the wards or from the ICU to the processing stations. Now, with the inception of the digital systems, we'll have direct right images right on a one click on the machine. We directly have the monitor inbuilt in it. We can see the X-ray images right into the ICU and take whatever views we required and whatever disease we required, disease diagnosis we required, we can take easily. Similar kind of development takes into the place of in the modality of the CT scanners. Witness initially the CT scan developed by the Alan Cormack and the Hon. To take the images. Now, with the advancement in the technology, we move towards from single slice to multi-slice, from 128 slice to 250 slice, and now we are using 320 slices. So with the inception or invention of these 320 slices CT scans, we can cover the body part in milliseconds. Around 16 centimeter of body part we can cover in 0.25 seconds. So you can imagine that in 1 second we can take a whole body images with the invention of these kind of CT scanners, and these kind of CT scanners and the due to development we'll able to see the different investigations, right? The cardiac imaging and the CT angiography is possible with that kind of advancement. Now we witness we are having the dual source CT and dual energy CT is also in market. So different kind of diagnosis, different kind of osteoporotic bones, diagnosis of osteoporotic bones disease is much helpful by using that kind of CT scanners. MRI also witnessed many kind of tremendous changes, right from the 0.5 Tesla to now witnessing we are at 1.5 Tesla, 3 Tesla nowadays have become normal CT scanners, and now it's moving towards the 7 Tesla, 9 Tesla based MRI systems are in place, and more of these things in future will witness some kind of open MRI. So pediatric patients can be imaged with the help of open MRI. So the main fear in some patients with MRI, the claustrophobic patients will answer with that kind of MRI. Also, the interventional radiology witnessed many kind of changes. Initially, we have the C-arm system, which have the bulky system. involve many kind of high amount of radiation doses. It's replaced by the flat panel detectors or the biplanar systems now we are having to that kind of distal systems. And also these advancement tends to not only take the anatomical image or the functional image. So we'll have the all limitations with the anatomical image. We won't be able to identify where is the disease. We can scan the whole body, but we won't be able to. And in functional imaging, we can try to find out the function of the certain body part, but where is its location and where it is, we are having some kind of difficulties. So answer for these kind of difficulties comes in the form of fusion imaging or the hybrid imaging. So it's a mixture of anatomical imaging as well as the functional imaging. So in which we club the anatomical imaging and the functional imaging, and we'll get our answers where is the location of the disease part and what kind of impairedness in disease parts having. So it's all possible with the help of these kind of hybrid imaging take place by the CT scanners clubbed with the positron emission tomography, so named as a PET CTs. So nowadays in nuclear medicine, we witness more and more PET CTs, and advancement also not taking place in the modalities, also in form of transformation of these modalities and accessibilities of these modalities, not only to the urban area, even in the rural area also in form of the teleradiology. So with the help of teleradiology, we can image the body parts in a certain place, and we'll take the images with the help of the data transfer system, which improved many folds with the help in invention of the technology and satellite advancement. So will any radiologist can diagnose or take the diagnosis in form of by sitting a remote place and taking images from the remote place and give his best opinion. So we'll have the best opinion, right? Not only the urban area, even in the remote area, we can have the updated diagnosis as per concern with the imaging or with the specialty. So these kind of changes tend into the field of radiation technology. And also now we are having the CAD, that is computer assisted diagnosis, means we'll have the X-ray images, we'll have some kind of parameters or radio markers in form of radio markers in imaging, will tend to learn the computer with the help of AI, teaching the computer to identify these kind of markers and prove his diagnosis. So that term as artificial intelligence in the radiology, and now we witness in future that more and more AI uses in the radiology to find out or to find a solution of our diagnosis questions. So these all kind of technology and advancements taking very rapidly in field of radiation technology, and being a radiation technology, being in the field, being in the educator of the field, we need to develop such kind of competency, not only to handle the X-ray machines, even handle the to higher sophisticated machines. So you can't expect from a bullock cart driver to drive a Sukhoi or the superior class aircraft. You need to develop the competency. So we need to keep the pace with the development in the radiation technology. We have to invest enough time to understand and update our knowledge about issues in newer technologies. The continuous development in technology will make it together for many radiological technologists to understand, correctly deploy these technology. And in if we think about the future perspective and future trends, so in Indian healthcare industries, we expect these growth growth in radiation technology around 15% per annum. So within next 5 to 10 years, this will keep demand for radiological technologies in quite high. So we need to develop the competency, and these kind of platform definitely help us to attain such kind of competency and keeps us the market ready product for the uh, field. So in short, both both exciting, and the future is both exciting and challenging for the practice of the radiation technology in India. And with the help, with the concluding words that undergoes these kind of many changes, we'll see that radiological advance from the scientific curiosity to the medical necessity in the today's era. And with all advancement in last 120 years, radiological has become indispensable in the patient management. And I hope such kind of CMEs and seminars will help to develop such kind of competencies, and help a great lot to us. So I thanks organizers to be a part of it. However, the presentations won't be able to see due to the technical glitch, and we'll see that in future we'll some more uh, interactions with you. So thank you for inviting me and being with us.
थैंक यू सर फॉर दिस नॉलेजेबल सेशन। और देखिए, आपने आज प्रूव किया कि एक अच्छा टीचर वही होता है जो अपनी प्रेजेंटेशन के बिना भी सब कुछ समझा जाए। तो आपकी प्रेजेंटेशन अब आई है इस पे, लेकिन मैं आपको कहना कहना चाहूंगा कि आपने जितना भी बताया वो सब हम सबको समझ में आया। एंड मतलब आपकी
Yeah.
बॉडी ही प्रेजेंटेशन है आपकी। थैंक यू सो मच फॉर योर टाइम।
Thanks, sir, for kind words.
Over to you, Renzi.
Thank you so much, sir, for your enriching session. Now we will move further, and now I invite Bhavna Gorak from DPT 4th year.
Namaste, I JVN Bhavna Gorak, BPT 4th year student from the Department of Physiotherapy and the Faculty of Physiotherapy and Diagnostics. Today I am here to present my presentation. So my title name is Robotic Rehabilitation in the Gait Training among Neck of Femur Fracture. So, introduction. The proximal femur frequently sustain femoral neck fracture, which are associated with high rates of morbidity and death among patients, as well as the elevated risk of avascular necrosis. So, these are the causes. The most frequent factor leading to femoral neck fracture is trauma. Falls are most common cause of femoral neck fracture in older adults, and which is more common in women. Femoral neck fracture are rare in children and most common in women. Clinical features: impacted and stress fractures, slight pain in the groin, and pain referred along the medial side of the thigh and knee. Displaced fracture, pain in the entire hip region. So, gait affect in intercapsular hip fracture. This sorting may affect gait by altering the abduction length tension relationship. This can result the affect abductor weakness and ultimately a Trendelenburg gait. Robotic rehabilitation. Robotic rehabilitation includes a wide range of stationary and portable electromechanical assistance training devices with the primary goal being to improve the functional mobility in those who have suffered from the neurological and traumatic events. The history of robotic rehabilitation. The MIT managed the first robot used in clinical studies to perform the robotic rehabilitation therapy was created in 1989. These are the advantages are the robotic rehabilitation, which is beneficial for the traumatic injuries and neurological injuries, which is providing functional mobilities and the functional mobility and functions and improve the gait pattern. And these are the techniques which is used in robotic rehabilitation, who are affected lower limb in the neck or femur fracture. Rehabilitation is more uh, improving pattern in the gait rehabilitation, which is beneficial for the rehabilitation. Lower limb fracture, which is most traumatic fracture, which is fall on the uh, 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 hip and these are the advantages. The assistance of robotic rehabilitation, patient can perform active or passive rehabilitation training, which is assistance from robotic rehabilitation robots. Medical staff don't have pay full attention to patient during the whole treatment process. The efficient treatment method helps to patient recover more efficiently, improving their quality of life. Rehabilitation robots are medical robots that assist human body to complete limb movements, and these are performing ergonomics, motion control, and other technologies used for providing the gait rehabilitation techniques. Realizing functions such as assistance, disabling walking, rehabilitation treatment, weight bearing and walking, and reducing labor intensity. Techniques which is used in robotic rehabilitation. So these systems are grouped according to rehabilitation principles they follow: standing gait trainers, foot plate based gait trainers, overground gait trainers, stationary gait trainers, ankle rehabilitation systems, stationary systems, active foot orthosis. Limitations: often robots are very costly in terms of the initial cost, maintenance, the needs for extra components, and need to do perform and tasks. Training in stationary gait robots and causes injuries and discomforts to the skin, underlying tissue, and musculoskeletal system, as well as the unwanted blood pressure changes. One advantage may be that the physiotherapist should be trained and skilled in using the device. Approximately motivating patient as well as therapists to use devices gait therapy might be challenged. Conclusion: robotic rehabilitation should be employed in fracture, neck or femur with functional disability to enhance gait rehabilitation. It will also increase strength and in lower extremity, improve posture, increase in bone density, decrease in cholesterol, bowel movement, improve sleep, decrease pain, and decrease spasticity. So, robotic rehabilitation can be helpful techniques for reducing gait impairments and as a result increasing the quality of life of patient. Thank you.
Thank you, Bhavna. Next, I call upon Ifat, BPD second year. Ifat, please unmute yourself and switch on your camera. Yes, Ifat.
Hello,
Now
good
you
afternoon,
can
everyone.
share your screen.
Yes,
Okay. By the meantime, Ifat gets connected, I will call upon Kiran from BMLT third year.
Namaste, I JVN Kiran Meena, pursuing BSc MLT 6th SEM from the Department of Medical Lab Technology under the Faculty of Physiotherapy and Diagnostics. Today, I am going to discuss on my title Remote Healthcare Technology. In In this PPT, we have presented and compared several low-cost and non-invasive health and activity monitoring systems. Wearable health technology is in the beginning steps of development and new technique for future of new development brands. In this paper, several communication technologies as well as future perspectives and technologies, research challenges in remote monitoring systems will be discussed. What is need of remote healthcare techniques? Improved access to healthcare, convenience and flexibility, enhanced continuity of care, timely and efficient medical consultations, cost savings, expertise and specialist access. These are the techniques: sharing photos or videos. We can ask to share photo or video of the current condition or specific symptoms. This will help your healthcare profession to understand more about condition by sharing files or videos with you. Second, wearable devices. Devices that can be wear, such as smartwatches, can help track a range of measurements of your current situations. There are some benefits of remote healthcare techniques. It enables people to get quality access to medical care, reduces the need for hospitalizations, provides proximity to home and community, provides rapid diagnosis and fast intervention by the doctors, enhance operational efficiency planning and compliances. It saves times and resources. It also reduces workload and improves clinical productivity. What are the future aspects of remote healthcare? Some out of them: telemedicine, remote monitoring devices, virtual reality, health data security and privacy, remote surgery, and robotics. These are some future aspects of remote healthcare techniques. At last, I want to conclude that it is also identified where technology can improve care, reduces inefficiencies, reduce the demand for facilities, and reduce costs. It provides increased care and disease management. It also provides urgent care online and virtually, reduces the demand for facilities. For examples, provide increased care and disease management in the home, provide urgent care online, virtually, provide continuity of care for chronic disease patients. Thank you.
Hey, Ifan, are you there?
Yes, ma'am.
Okay, you can continue. Please switch on your camera.
This.
Yes.
Click on this. Click on this. Ma'am, is it visible?
You are visible. Yes. Yes. Yes, you can continue.
So the topic is evolving physiotherapy technologies in healthcare. Um, the objective of this paper is to explore the current state of the emerging physiotherapy technologies in healthcare and the potential in the field of it. These technologies have the potential to significantly improve the effectiveness and the efficiency, leading for better patient outcomes. They have also revealed that these technologies include virtual reality and everything, and they improve the patient engagement and increase the treatment protocols and enhance the precision and accuracy of these physiotherapy interventions. But however, there are also challenges that are associated um, of these technologies into clinical practice. The aim of this is to investigate the current state of the technologies and their potential implication. They also include the development of health, whether it be mental, social, emotional, and physical. These technologies play a crucial role in the healthcare. These technologies include virtual reality, wearable devices, robotic exoskeletons, and telerehabilitation, etc. These advancements help therapists diagnose more precisely, and they increase the clinical efficiencies, improvement engagements, and have better patient care. We hypothesize that these emerging technologies into clinical practice has the potential to significantly improve the effectiveness and efficiency, leading to better outcomes. These technologies have a potential to revolutionize by providing practitioners with innovative and effective options. Therefore, these have the potential to improve the patient outcomes in the field of physiotherapy. But further research is needed to fully understand the benefits and how they can be um, put into practice. Our analyses have revealed that these technologies have shown great potential in improving the patient engagement and are increasing the adherence for the treatment protocols and are enhancing the precision and accuracy. These technologies have also provide patients with more engaging and motivating experiences, leading to better patient adherence and better outcomes. These technologies are promising and offer exciting new ways to improve the outcomes and enhance the quality of care given by the therapists. The implications for these technologies are significant. Adoption of these technologies have a potential in this field and can lead to better outcomes, efficiency, and reduced healthcare costs. However, the challenges that are associated include related to cost, usability, and access to these technologies. Another important application is that they enhance the efficiency and implication in the care of delivery. Finally, these technologies have an important implication for the future of this profession. In conclusion, these technologies can uh, have significantly improved the effectiveness and efficiency. The goal, after all, is to make it easier for the patients to complete their entire course of care, including the parts that they have to do outside the clinic. These technologies can transform the field of physiotherapy in the future and can shape the future of this profession. Despite all these challenges, the potential are significant. Thank you.
Okay, thank you, Ifar. Thank you
Thank you
for
so much for
your
giving me this opportunity.
Thank you. Okay, next we will further continue with next presentation. Now I call upon Muskan Farooq, BSc RT third year.
Good afternoon to all of you. I, JBM Muskan Farooq from the Department of Physiotherapy and Diagnostic under the Faculty of Radiation Technology. Today I am here to present my PowerPoint presentation on the topic of recent advancement in radiotherapy. As we move further to the presentation, let's have a look to the content here. I will start first with the introduction, followed by the stereotactic radiotherapy, then gamma knife, cyber knife, flash therapy, and I end up here with the conclusion. Sorry for this error. I will repeat. I, JV Muskan Farooq from the Department of Physiotherapy and Diagnostic under the Faculty of Radiation Technology. Today I am here to present my PowerPoint presentation on the topic of recent advancement in radiotherapy. Before I move further to the presentation, let's have a look to the content here. I will start first with the introduction, followed by the stereostatic radiotherapy, then cyberknife, gamma knife, flash therapy, and I end my presentation with conclusion. Firstly, stereotactic radiotherapy. Stereotactic radiotherapy is an advanced technique that is used in the radiotherapy to deliver the higher doses of radiation from the different angles to our body. The beam meets the tumor. As a result, the tumor receives the higher dose of the radiations, and around surrounding tissues will receive the lower dose of the radiation, and this will reduce the side effects. The machine that are used in the stereotactic radiotherapy are gamma knife, cyber knife, and linac-based X-ray knife. Stereotactic radiotherapy has been divided into two categories: stereotactic radiosurgery and stereotactic body radiotherapy. Firstly, we will discuss the stereotactic radiosurgery is used for the treatment of CNS, that means the brain and spine cancers with a single fraction, means with a single go. The machine that is involved in the stereotactic radiosurgery are gamma knife, cyber knife, and linac-based X-ray knife. While the stereotactic body radiotherapy is used for the treatment of extracranial tumors with 3 to 4 fractions. The machine that are used in stereotactic body radiotherapy is cyber knife and linac-based X-ray knife. My next slide is about the immobilization equipment. Immobilization equipments are those equipments that are used to stable the patient throughout the procedure. In gamma knife, immobilization equipments are used as head frames or helmets that are screwed to our outer layer of the skull through the skin under the influence of anesthesia and sedatives. Such helmets include selection helmet and BRW helmet. BRW means brown robot helmet and mouth bites. Some of the side effects of gamma knife are new onset of the severe headaches, numbness, new seizures, vision problem, swelling, hair problems, scalp problems, inflammation, etc. Now we will discuss about the cyber knife. Cyber knife is the most advanced and it's the world's first and only intelligent robotic radiosurgery system. As per the robotic nature, it can deliver the non-surgical stereotactic treatment with sub-millimeter accuracy anywhere in the body, including the prostate, liver, and the spine, extra. With the great accuracy, cyberknife is a good option for the tumors that can be movable. When a person breathes or that tumors that moves as a result of change in the bowel or the bladder filling. For examples, lung tumor, kidney tumor, pancreatic tumors, and prostate tumors. I have here displayed the diagrammatic representation of the cyber knife. My next slide is about the flash therapy. Flash therapy is a new technique that is used for the treatment of tumors with the ultra high dose rate that actually reduces the side effect to the normal tissues. Flash therapy is more beneficial than conventional radiotherapy as it gives more protection to the normal tissues than conventional radiation therapy. For example, if a patient undergoes the 30 days of treatment, it can be done in a single treatment with the help of flash therapy in less than 1 second. But flash therapy is not implanted in India yet. It is used in foreign countries nowadays, but it will be implanted in India also in future. And I end my presentation with a conclusion. Here, my conclusion is the RD has undergone a tremendous progress over the years and have modified the treatment strategies that lead to the enhanced patient survival rate and the therapeutic gain. Involvement of such, as I already mentioned above, such advanced robotics or artificial intelligence, we will achieve more accuracy, more we will enhance the patient survival rate, and the treatment will be painless. At last, the more advancement in the radiotherapy treatment or techniques, the more we will benefit the patient's treatment. Thank you. I, Thank you so much.
Thank you, Muskan. Now I call upon Ekta Prajapat, DPD 4th year.
Namaste, I Jivin Ekta Prajapat from BPT 4th year from the Department of Physiotherapy and the Faculty of Physiotherapy and Diagnostic. My title name is Pilates in the low back pain. So, the low back pain can result from the many different injury, condition or disease, most often an injury to the muscle or tendon in the back. The pain can range from the mild to severe. The Pilates method was developed by the Joseph Herbert's Pilates and consists of comprehensive body conditioning, which aims to develop the body awareness and improvement the posture. The Pilates is a system of exercise using special apparatus designed to improve the physical strength and flexibility and posture and enhance the mental awareness. The six essential principles of the Pilates. First, it is centering, concentration, control, precision, flow, and breathing. The benefit of Pilates. The Pilates focus on the core strength, flexibility, and posture and improve the core stability and strength, enhance the flexibility and posture, reduce muscle imbalance and tension, and increase the body awareness and relaxation. The mechanism of Pilates in low back pain relief. The key mechanisms are first, it is strengthening of the deep core muscle for better spinal support, activation of the pelvic floor muscle for improve the stability, and stretching of the lengthening to tight muscle relieving the tension. The key aspects of the Pilates technique: the core engagement, control, breathing, integration of the whole body, and equipment and made best exercise, and the concentration, precision, alignment, flexibility, and strength and adaptability. Conclusion: the Pilates exercise can potentially be an effective approach for managing the low back pain. That combination of the core strengthening, flexibility, body awareness, and posture alignment promote in Pilates can contribute to reduce pain, improve the functional ability, and enhance the overall well-being. Thank you.
Thank you, Ekta. Now I call upon Ayushi Parekh, DPD 4th year.
Namaste, myself JV Naresh Parekh from the Department of Physiotherapy and Diagnostic. Today I am going to represent a presentation on the topic of taping in lymphedema. The lymphedema, it is a chronic condition that causes fluid to build up in one or multiple areas across the body, producing enlarged or swollen limbs. The signs and symptoms that include the signs and symptoms that are included in lymphedema patients shows swelling of part of all the arm or leg, including fingers or toes, a feeling of heaviness and tightness in muscles, restricted range of motion, recurring infections, hardening and thickening of the skin. This this diagram, this picture shows normal lymphedema to moderate lymphedema in lower limb. General management of lymphedema, access to general
The general management of lymphedema exercise. The exercise include gentle contraction of the muscles in the arm and leg to improve the excessive fluid out of the swollen limb. Manual lymph drainage, compression bandages, compression garments, and sequential pneumatic compression. Kinesio taping. Kinesio taping for lymphedema. It is done in a fan cut taping type in which the anchor of the tape is gently placed on the posterior part of the popliteal fossa downward toward the leg. For ankle swelling, the kinesio tape is applied on the upper calf, the part of upper calf to the top of the foot. It is applied in a wave pattern in 4 tails. Um, these are the references I have used in this PPT. Thank you.
Thank you, Ayushi. Now we'll take a break. It's a lunch time.
It's a lunch time, so we end up the pre-lunch session here, and sharp 2 o'clock. Everyone be there, and we'll start post-lunch sessions at sharp 2 o'clock. Thank you so much. Welcome, Dr. Vikram. We'll start our session, post-lunch session, in 5 minutes. So just wait for 5 minutes.
Okay. Can you hear? Can you hear my voice?
वॉइस थोड़ी सी कम है, तो थोड़ा सा देखो अगर
अभी आ रहा है?
हाँ, अभी बेटर है, मच बेटर.
ठीक है. Okay. शॉर्ट ड्यूरेशन है ना, कई सारे स्पीकर्स हैं. तो अभी तो इतना छोटा मैटर निकाला है उसमें से. भागो घर. मोबाइल साइलेंट कर.
Okay, now we are going to start our post-lunch session. So I introduce our eminent speaker, Dr. Vikram Bhadoria. He is the president of RPPA. And sir, I really warm welcome, and you have spared some time from your busy schedule for us. And over to you. And thank you so much for your time.
Thank you, Dr. Ankit Bhargav. And first, I introduce myself. For myself, Dr. Vikram Badal, is a neurophysiotherapist, and I am treating my patients last 15 years in Bareilly and different states and different districts in Uttar Pradesh. And today, my topic is recent advancement in health technology. So, in time of crisis, eminence creative often comes to the fore. Participating major changes. This has been the case in the coronavirus disease 2019 COVID-19. Era healthcare technologies has leaped to the fore to help healthcare providers manage their patients better by reducing the danger inherent in personal contact, waiting in crowded waiting rooms or laboratories and hospitalizations. So first, we are working and we are introduce artificial intelligence, how we can work with this technologies, artificial intelligence. Artificial intelligence is being used in the diagnosis of disease as well as to offer customized solution. For instance, it is being used to drive system that process computed tomography scans by the thousands in a mass detection scenario as in COVID-19. This spares radiographers and physicians to attend the patients beside providing supplementary information and thus improving the accuracy of diagnosis and monitoring. Machine learning is being exploited in the pharmaceutical industry to identify new drug candidates without the long and expensive traditional methods of sifting through chemical libraries, while also replacing actual experiments with simultaneous varying multiple parameters. The whole process is not only much less expensive but also much faster. Machines learning is being exploited in the pharmaceutical industry to identify new drug candidates without the long and expensive traditional methods of sifting through chemical libraries, while also replacing actual experiments with simultaneous varying multiple parameters. The whole process is not only much less expensive but also much faster. Future of smart health systems. Robotic systems are being developed using all AI and machine learning to replace humans in the performance of routine unskilled tasks now being done by skilled healthcare practitioners. This will free them to treat more patients with less time pressure, promoting a favorable outcome. Essential to prevent, detect, and plug data breaches as soon as possible. The rise of M-Health. Maybe this is something new. To handle this needs mobile health information and sensing technologies termed M-Health has gained prominence. These tools seem to offer the ability to provide healthcare at lower cost. With improved outcomes, they can allow a limited number of providers to monitor more people individual and at the population level. Application of M-Health can promote healthy behaviors for primary and secondary disease prevention, help with the self management of chronic illness, improve providing training, and cut down on visits to the doctor. At the same time, they can help personalize intervention to an unprecedented levels. Today, M-Health can be utilized in the form of mobile device, wearable, and other devices that allow people to carry on with their routine activities, while the device sends invaluable data on a host of parameters back to the server. This data can be used both in the present and the future to provide information on kinds of trends and predictive factors to help research-driven efforts to promote and improve health patients. Multiple platforms are now available backed by top-class information technologies IT firms like Apple to facilitate the development of healthcare apps. Telemedicine. Telemedicine is an important innovation now practiced in many countries worldwide due to pandemic restriction on public travel. With this technology, clinical practitioners see patients virtually, avoiding personal contact while still being able to diagnose and treat patients for a host of illness. The saving of time and money has made this an attractive option for both patients and practitioners, and this trend seems unlikely to die down soon. Virtual reality. Augmented and virtual reality is being used in novel ways to distract nervous patients from surgical procedure or help train medical students outside the hospital and without the risk of harm to actual patients. A hands-free mode of operation is also enabled, allowing providers to access patients' records to other information without leaving the patient or stopping the procedure they are engaged in. The Internet of Medical Things. The Internet of Medical Things IOMT comprises a network of device and mobile phone apps that track and prevent serious events in the course of chronic illness, lagging patients and doctors for better monitoring and management of such condition. For instance, bereavement. Cloud computing. With patients' data being a dynamic thing, it is essential that healthcare providers have a safe and smooth method to share and store this data, on which their clinical decisions are based. Cloud computing offer an excellent way out wherever data collection, storage, and management can be achieved using a single point. The resulting improvement in patients' care with the saving of time is almost among the benefits of this approach. And another thing is nanotechnology. So this is the conclusion of all my topic, recent advancement in healthcare technologies. At conclusion is overall my talk is for medical technology standards and regulation are needed to ensure safety, protect the public, and guarantee that the products are fit for purpose. However, in the context of novel and personal medical technologies, the current approach to regulation is not only infeasible and difficult to enforce, but also work against the healthcare innovation. At the same time, with the realization that human nature remains the same and at the same time with the realization that human nature remains the same and that the real aim of technology has always been profitability, it is obvious that newer health technologies need to be vigilantly monitored by new regulatory frameworks so that the patients continue. It is obvious that the newer healthcare technologies need to be vigilantly monitored by new regulatory frameworks so that patients continue to be benefit and keep at the center of healthcare. Thank you, Dr. Ankit.
थैंक यू डॉक्टर विक्रम। और मैं आप सबको ये भी बताना चाहता हूँ कि इनका बहुत बड़ा रोल है यूपी की काउंसिल बनाने में, और आरपीपीए ने बहुत अच्छा काम किया। इनसे पहले आप लोगों ने डॉक्टर मुदगिल को सुना, वो उनका हरियाणा काउंसिल में बहुत बड़ा रोल था एचसीएपी का। ऐसे ही आरपीपीए जो है वो यूपी की सबसे बड़ी एसोसिएशन है जिसने अपना सब कुछ लगाया काउंसिल बनाने के पीछे, और उनके जो ये अध्यक्ष हैं इनका बहुत बड़ा रोल रहा है डॉक्टर विक्रम का। और आपका प्रोफेशन के प्रति जो डेडिकेशन है उसको हम सब सल्यूट करते हैं, और ऐसे ही आप अच्छा काम करते रहिए और हम आपके साथ हैं।
विदाउट अ सिंगल फिजियोथेरेपिस्ट मैं कुछ नहीं हूँ, ना आरपीपीए कुछ है। आप लोग मेरे साथ हैं, इसलिए आरपीपीए आज है और आगे भी रहेगा। और यूपी नहीं, इंडिया में किसी भी फिजियोथेरेपिस्ट को अगर मेरे लायक कोई हेल्प की नीड है तो मैं आई एम ऑलवेज विद माय प्रोफेशन एंड आई एम ऑलवेज रिस्पेक्ट माय प्रोफेशन एंड आई एम प्राउड टू बी अ फिजियोथेरेपिस्ट।
और एक चीज और है कि आरपीपीए का एक यूनिक प्रोटोकॉल चलता है कि डिफरेंट क्लिनिक्स इनके अंडर इन्होंने टाइप्स कर रखे हैं, एंड होपफुली डॉक्टर विक्रम हमारी आगे आने वाले दिनों में मदद भी करेंगे कि हम कोशिश करेंगे कि ज्योति विद्यापीठ को हम इनके साथ टाइप कर दें ताकि हमारे बच्चों को आगे फ्यूचर के लिए जॉब्स के लिए इतनी ज़्यादा टेंशन हो नहीं। थैंक यू डॉक्टर विक्रम।
थैंक यू डॉक्टर अंकित भार्गव,
आपके वैल्यूएबल टाइम के लिए, एंड थैंक यू सो मच। ओवर टू यू रेंसी।
Thank you so much, sir, for your enriching session. Now, as continuing with the second session of our day, I'll call upon Ritika Jain, student of BPT 4th year.
Namaste. Myself, Namaste, all the higher dignities and faculty members. I'm JVN Ritika Jain from BPT 4th semester. I'm pursuing Bachelor's of Physiotherapy from the Department of Faculty of Physiotherapy and Diagnostic from Jyoti Vidyapith Women's University. Today I'm presenting the topic Advanced Physiotherapy Methods Used for Recovery in Stroke Patients. So this is the introduction part. So basically what is stroke? Stroke is a rapid loss of brain function due to the disturbance in the blood supply to the brain. It will occur when the blood vessels in the brain ruptures or damages due to any cause, just like head injury or anything else. So, according to WHO, the symptoms will last longer than 24 hours or it eventually will lead to death of the patient sometimes. And it mainly caused due to cerebral infection, intercerebral hemorrhage, and subarachnoid hemorrhage. The epidemiology is the stroke is commonly affects 1.54% people among the 1,000 people in India, and death rate due to stroke is 0.6% per 1,000 people. So there are three types of stroke: ischemic, hemorrhagic, and transient ischemic stroke. So ischemic stroke basically signifies when there is a clot in the blood vessels that is supplying to the brain, which leads to the damage of the blood vessel. So that will prevent the blood and oxygen reaching to the brain cells, and hence leading to the damage of the brain tissues, leading to extensive paralysis of the limbs. And second is hemorrhagic stroke. It will occur when the blood vessel in the brain ruptures and leaks out, lead to the hemorrhage of the blood cells, and then it will rupture all the brain tissues. So that will lead to paralysis. Transient ischemic stroke is basically a symptom that will occur 6 months before any kind of stroke that is occurring in the preceding months. So next we will go on to the symptoms. So symptoms of stroke includes the basic first symptom is paralysis. Paralysis can be of only the single side of the limb, or both the limbs, such as hemiplegic patient, in which the hand and the legs are paralyzed along with the trunk, and it can be diplegic or quadriplegic. Some of the following symptoms that we can see in a stroke patient include slurred speech, sudden behavioral change, especially increased agitation, trouble walking, gait changes, loss of balance and coordination, severe या फिर sudden headache होगा, कोई उसका cause नहीं होगा, but the patient will feel headache around the brain side, and seizures, nausea and vomiting. So today I'm presenting the methods, the modern treatment methods that can be used for the stroke patient. So basically, the first method is electromechanical assisted gait training. It is used to improve the gait or ambulance in the stroke patient, because the gait is actually being unstable or the patient is unable to walk. That is due to the circumambulatory gait pattern. So electromechanical assisted gait training can be done with or without partial weight bearing. So automatic gait training, electromechanical gait training we can use, or we can use normal electromechanical solution, which includes two driving foot placed stimulating the phases of gait. So the current researches indicates that repetitive gait training in combination with physical therapy may improve walking ability in patients with stroke. So I am sharing the diagram, which is showing a physiotherapist standing beside the patient, checking whether the patient is not fainting or anything while doing the repetitive walking on the setup that we have provided him, that is working automatically. Okay, so next slide. Uh, The second method we can use in modern technologies include rhythmic cueing. Motor control researchers provide considerable evidence that auditory rhythm, example, music can improve the timing and variability of the motor responses. For example, if a person is walking normally, stroke patient is walking, then he will walk with slow speed. But if we provide him with appropriate music that he likes, then the speed of his gait will improve and hence the walking pattern of the patient will improve. So it is a basic method that we use in new physiotherapy methods to improve the gait of the patient. So the next method I have, I have found that is virtual reality. Virtual reality is basically a most modern method and is most commonly used by the stroke patient and the Parkinson patients. So advances in virtual reality technology means that devices using computer and gaming technology such as Nintendo Wii are found in many people's homes. So I have told already that it is used by many people to improve their functional ability. So these type of modalities are basically used to maximize the task oriented practice and increase the energy expenditure to the so that the beginning of these can be explored. Virtual reality training can also be used in gait training and also to improve the function of the upper limb of the patient that is affected. For example, games like football, in which the patient does not perform anything but is wearing the virtual reality modality, that will lead to think him of that if he is playing the game, so it will improve, it will lead him to move his leg, the affected hemiplegic leg. Okay. So next, I am using mirror therapy for hand recovery. Mirror therapy is basically the most cheapest and the most easy and handy treatment that can be used for improving the hand paralysis or when the patient has very limited hand movement. Okay? So in this, the patient is already know that he is moving one hand, but it tricks the brain into thinking that you are moving both the hands. This helps activated neuroplasticity and slowly improve the mobility in the affected hand. So the patient here is picking a ball in his hand, but she is thinking that she is using both the hands. The last we have seen is hyperbaric oxygen therapy. सो व्हेन बेसिकली स्ट्रोक किस वजह से हुआ है, बिकॉज हमारे ब्रेन को क्या हुआ, ऑक्सीजन की बहुत ज़्यादा डेफिशिएंसी हो गई, इस वजह से हमारे बॉडी के अंदर स्ट्रोक आया है. सो हाइपरबेरिक ऑक्सीजन थेरेपी इज अ ट्रीटमेंट दैट प्रोवाइड्स पेशेंट विथ 100% ऑक्सीजन in the pressurized environment. So when we increase the amount of oxygen in the body, it will improve the healing of the brain cells that have become injured during the paralysis or during the when the stroke have occurred. When we combine hyperbaric oxygen therapy with repetitive exercises, this will boost the recovery process and promote the return of both physical and cognitive function. So these are the 5 methods that I have used to treat the stroke patients. So thank you.
Thank you, Ritika. So for next presentation, I would like to call Maisara from BMLT third year. Good afternoon. I, Jagan Maisra Jang, pursuing BSc MLT from the Department of Physiotherapy and Diagnostics. I am going to present my presentation, which is on modern technique for detection of viral infection. First of all, we will see the introduction of virus. Viruses are smallest infectious microbe consisting of segment of nucleic acid, either DNA or RNA, surrounded by a protein coat which we call capsid layer, which protects the viral genome. So let's see the example of pandemic viruses in past years. like coronavirus and influenza virus are the pandemic viruses. After that, we will see the components of virus. They are enzyme, genome, capsid, and envelope. After that, we will see the traditional laboratory methods for diagnosis of viral infection. Complement fixation test and heme agglutination test are the traditional laboratory methods for diagnosis of viral infection. In complement fixation test, we detect the antibodies in serum. In serum, we detect the antibodies. They react with antigen until complement is not used, and if there is no hemolysis then the result is positive, and if there is hemolysis then the result is negative. Then we will move on to another traditional laboratory methods, that is heme agglutination test. In this test is generally used for detecting arbovirus, influenza, para-influenza virus subtypes, and this technique is basically principle relies on the capacity of hemagglutinin, a viral protein present in the envelope, to bind erythrocytes RBC and to form a latex pattern. Serum are added with a fixed amount of viral hemagglutinin. Let's move on the limitation of complement fixation test. They are not sensitive and time consuming. And the limitation of hemagglutination test, sensitivity is low and not all viruses contain hemagglutinin. Let's move on to modern laboratory methods for the diagnosis of viral infection. First, we will detect the antibody detection, that is ELISA, immunofluorescence assay, NAT, RT-PCR, and multiplex PCR. First, we will discuss the ELISA. ELISA means enzyme-linked immunosorbent assay. ELISA, ELISA is an enzyme-facilitated colorimetric detection in which we detect antibodies. ELISA can be sandwiched, computative, and indirect. In sandwich and indirect tests, color development denotes the presence of an antigen and antibody, but in computation assays, color development implies a negative response. Then after we will move on RT-PCR, which is another modern technique of the virus diagnosis. That is RT-PCR, which we call real-time PCR or reverse transcription PCR. This technique is used to detect the diagnosis of various pathogens, including RSV. It's a rapid sensitivity and specific method was devised based on the Tagman real-time PCR. First, in this technique, the RNA is converted into DNA, and then that DNA is done by the another technique which we call PCR, which is polymerase chain reaction. After that, we will see the benefits of modern technique. They are highly specific and sensitive. They are quickly performed 4 to 8 hours, simple and fast, and and data is given appropriate. Thank you and so much.
Thank you, Maisra. Now I call upon Komudi, Biooptometry, third year.
Namaste to all of you. I, JVN Kaumudi Pandey, pursuing Bachelor's of Optometry, third year, from the Faculty of Physiotherapy and Diagnostics. Today I am going to present in the front of you, which is hypertension and the eye. Hypertension was formed in the bo- hypertension was formed in the body. Small blood vessels narrow, causing the blood pressure is increased in vessels, causing the hypertension. Hypertension normal reading is 130 by 80 and higher is measured in mmHg. Types of hypertension. Hypertension Primary hypertension is are not associated with another disease and not find these causes. There are 90 to 95% cases. Secondary hypertension is associated with another disease like a tumor, any cough and cold medicine, heart, congenital heart disease. There are cases in 5 to 10%. What is the causes of hypertension? Just like smoking, overweight, lack of physical activity, too much diet in salt, alcohol, older age, genetic and stress. Some symptoms and hypertension: headache, blur vision, chest pain, dizziness, stroke, reduced eye vision, blind spots in eye swelling, etc. Signs. Uh, Signs. I When we notice blood pressure in body, increase IOP, intraocular pressure, flame shaped hemorrhage in eye, blur optic discs, prominent blood vessels. Pathology of hypertension. Pathology, how to hypertension affect in our body. The hypertension increase arterial hole restriction, causes the blood flow in restrict and increase hypertension. There are many complications in the eye due to hypertension. Some causes just subconjunctival hemorrhage. Subconjunctival hemorrhage in flame-shaped hemorrhages look in subconjunctival tissue. Hypertensive retinopathy. Hypertensive retinopathy causes the retinal damage. The blood vessels are narrow and new vascularization. Hypertensive optic neuropathy. Due to hypertension, optic neuropathy, nerve are blocked and the signal of eye to not send to retina to brain. Hypertension choroidopathy, it is a condition to chronic high blood pressure. The choroid layer is vascular layer. The blockage of vessels in hypertension to form choroidopathy. How to management how to management hypertension. First of all, diagnosis. History. First of all, we take history, family history, medical history, ocular history, systemic history of patient, physical examination, just like weight and height, laboratory test, blood pressure test, visual acuity in eye, dilated eye checkup, slit lamp by स्लिट लैब बाय माइक्रोस्कोपी से आई एंटीरियर सेगमेंट को देखेंगे, ऑप्थेल्मोस्कोप से आई के पोस्टीरियर सेगमेंट को, टोनोमीटर से चेक आईओपी, प्रेशर इन आई. ट्रीटमेंट. फर्स्ट ऑफ ऑल हम लोग ट्रीटमेंट लाइफस्टाइल चेंजेस, eat a healthy diet, excessive regular, quit smoking, maintain the weight and lose weight. There are some medication to provide the patients, beta blockers to reduce the blockage of nerve, and if vision loss of eye, to treatment LASIK treatment and provide surgery. Conclusion: blood pressure is a primary causes. It can already to patient hypertension and regular checkup, provide to patient prevention in causes, problems, and control hypertension to changing lifestyle. Thank you.
Welcome, Dr. Lewis. Seeing you after a long time. And I just further, I just introduced Dr. Lewis first. He is a professor at Argentina School of Lymphedema, and he's a renowned doctor and a kinesiotaping specialist. And he's actually a mix of, he's, I think, very few doctors in the world who believe in kinesiotaping. and he works a lot on kinesiotaping. And I think you also taking care of Argentina kinesiotaping also, right? Yeah. And thank you, really, thank you from my side, because you have, on a very short notice, you accepted my invitation. And I understand that's early morning in Argentina, and I wake you up. So
Thank you.
thank you so much, and I warm welcome you on in this conference. Over to you, sir. Thank you.
Oh, uh, hello. Thank you very much, Professor Ankit Bhargava. Thank you for invitation. It's a pleasure for me to be here sharing our experience and the invitation from the Hayoti Vidyapeeth Women's University of Jaipur, India. Thank you very much also for all of your words. I will begin. I will begin to share my presentation.
Dr. Louis, just click on the present button, and there you will see the entire share entire screen.
Okay. Excuse me.
It will take some few seconds because of the time lag. I think if you can able to see the share your slides on the screen. Yeah, it's come up. So you can yeah, but the
Um,
presentation is not yet open. Your screen showing that.
oh, hi. Can you see my presentation?
No, I can see your screen. Presentation might be, it will come up. Just wait for a few seconds.
Okay.
I can see the document and this thing, but I'm not able to see the presentation yet. But I can able to see your screen. I think open the file. I believe so.
Um, at this moment, can you see it?
Not yet. Let's wait for a few seconds. Once again, double click on the file,
Okay.
Dr. Liz.
Okay. Can you see here? Can you see now?
Still, your screen is coming only, but there is no presentation that's coming up.
At this moment?
Mm, just waiting for a few seconds, so maybe because of the time lag, it will be a problem.
Okay. I'm trying to share.
Again, the same screen has come up, the document section of your screen.
Okay.
I think he got disconnected, so we'll wait for a few minutes. just after sharing the screen, once the screen come up on screen, you just double click the file. So this the file will open automatically, and we
Okay.
can able to see that.
I will I will search in the presentation now. Here. I now the uploading. In my screen, the presentation is uploading at the StreamYard.
But in the meantime, yeah, now your screen come up. It's uploading.
Okay, can you see
Yeah.
now?
Yes, we can see now.
It's okay. Is it okay? Perfect. Okay. Oh, excuse me for these troubles. Well, I will share our experience in the lymphedema, how we can treat the lymphedema in our team. For example, as you know, lymphedema is a chronic disease, in these cases, in a leg, in the arm, but sometimes there are some big, very, very big lymphedemas in these patients. Primary, for this case, in the man in the left, and secondary after breast cancer in the woman at the right. But what can we treat these patients? This is our professional protocol. First, we perform an evaluation. Second, a diagnosis. Third, indications. Four, objectives and therapeutic strategic. And finally, the new patient evaluation to um, reperform the protocols. What can we do? The evaluation by clinical questions, by, for example, the interrogatory, the disease, other disease, the implications, pain, limitation, functionals, and also the edema. Also the physical and psychological examination is very important to determine the volume and the status of the lymphedema, the local complications such as infection like erysipelas, cellulitis, pain, ulcers, wounds, and we live in an undeveloped country, so there are so important the economic and social factors, and of course the compliance of the patients and their family. It's very, very important of all of these points. As you can see, the both patients have a primary or congenital lymphedema, but the body, the edema, the skin, the conjunctive tissue are very different between both. For example, in the left, the case is not so hard, but in the right case, you can see also ulcers, cellulitis, very, very big implication in the skin, in the fat tissue, and social, psychological, and functional disturbs and troubles. In the second point, we perform the clinical questions to perform the diagnosis, and after that, the physical exam, complementary exams, for example, duplex scan to have an examination of arterial and venous states, and for example, tomographies, or more specific, lymphographies, with radionuclide or with indocyanine green. And also very important to perform the volume measurements and image registration with frames or slides or videos. In the arm, the most common lymphedema is after breast cancer. In the left, you can see not so much repercussion or not so much problems, not so much symptoms. But in the right, you can see a big tension of the swelling of the edema, and also a very big recidiva at this place. Which are the indications? General or conservative treatments. General treatment of the pain, of inflammations, of infections, and the combined physical treatment, surgical treatment in some cases, and also the preventive recommendation in all the patients. But the treatment that we perform with a with a team, with physiotherapists, physicians, nurses, we perform manual lymphatic drainage, intermittent pneumatic compression, multi-layer bandages, inelastic compression with zinc oxide, inelastic compression, for example, like wrap, or elastic sleeves and socks, and always the skin care. Here, when we are doing the manual lymphatic drainage, and here the intermittent pneumatic compression in the arm and in the leg. The multi-layer bandage in the arm, also in the finger, and elastic socks, this with a high pressure, for example, 30 to 40 mercury millimeters. And the combined physical treatment also includes lymphatic taping, such as mentioned Professor Ankit Bhargava, shockwaves, devasylation, topical creams, specific exercises, advanced wounds and ulcers treatments in some cases, and optional ultrasound magnetic treatment. Here, the kinesiotaping, we use so much this kind of treatment. The inelastic wrap, the shock waves. But as you can see, there are a lot of different kinds of physical treatments, but like a restaurant, you have a lot of options to choose, but it's impossible to apply, to do all these kind of treatments in all of the patient. So you can choose, you should choose this treatment, this combination of treatments for according the patient, according our um, our logistic, our experience, professional, according also the economic, of course, economic possibilities. So, like a restaurant, you should and you can choose the different combination for your patients. And the the final point is the new evaluation. For example, at the beginning and the 12th session of combined therapy physical. At this moment, you can choose how we can go ahead, how we can continue with this patient with the same treatment, or sometimes we can change the indications. For example, at the beginning, this young woman with a primary lymphedema in her right leg with important repercussions, with important functional disturbs, psychological pain, etc., and with manual lymphatic drainage, intermittent pneumatic compression, multi-layer bandage, exercises, and after that, we can, with all the team, we can arrive at this point. And after that, we can choose, for example, a surgical complement, a complement treatment, for example. Like conclusions, the treatment always should be adapt each situation. The therapeutic team with a combination of all of the colleagues, physiotherapists, physicians, nurses, professors, psychologists, etc., is essential. And always the improvement of the quality of life is our goal. Thank you very much for your attention.
Thank you, Dr. Lewis, for this wonderful presentation. I always enjoy your presentation on lymphedema because very few people they are working on lymphedema so deeply, and I would definitely maybe in future if everything goes well. So I'll definitely invite you physically to India so that you can show your lymphedema treatment talent to our students. So I am planning, and definitely I'll call you up to India, and you can enjoy our culture also.
Oh, thank you very much.
Thank you so
It
much
will
for
be a
your time.
pleasure for me. Thank you very
Thank you.
much.
Thank you. So now we can proceed further with our next eminent speaker, Dr. Shilpa Jain. She is an associate professor and HOD in Dipsar, Delhi, and I heartily welcome you, ma'am, for your and thank you so much for your time on a very short notice. Over to you. Thank you.
Thank you, Dr. Ankit. The entire team members, respected patrons, co-patrons, everybody, I would like to thank you all for inviting me as a speaker for this wonderful conference. So without wasting much time, I would like to share my presentation. Okay, Dr. Ankit, is my screen visible? Presentation visible?
Yes, ma'am.
Yes,
It's
yes, yeah, yes, Shilpa, please continue.
Okay. So, good afternoon, one and all present here. I, Dr. Shilpa Jain, Head School of Physiotherapy, would like to speak about emerging physiotherapeutic technologies in health and further an approach towards myofascial pain syndrome. It's not working actually. Next slide is not coming. I really don't know what is happening.
एक बार उसको मिनिमाइज मतलब वैसे छोटा करके एंड देन एक एक करके चलाओ.
ओके, ठीक है.
फुल स्क्रीन पे ना करके उसको छोटा करके देखो एक बार. हाँ, अब चलाओ.
Is it fine if
हाँ,
I
दिख
go
रहा
with
है,
this only?
परफेक्टली फाइन.
Okay, thank you so much. Sorry for this hiccup. So I would like to ask one thing, or would like to let you think just for once, that what is the most beautiful creation of God? Is that the sun, the moon, the stars, the days and nights, springs, wells, flora, fauna, everything created by God has its own role. But I would say the most beautiful creation is the man himself, because the humans have the feelings to think, to create a change, to have the emotions, everything they can change with this brilliant mind and this body. And we all know that the human body is a complex system of organs and tissues that really work together in a coordinated manner, in an interdisciplinary manner, to perform various functions necessary for the survival. Each organ has a specific role to maintain the body's homeostasis or the balance. And we all know that if any one of the system or organ doesn't function properly, it can affect the function of other systems too. So if the human body itself is working with interdisciplinary manner, then why we physiotherapists cannot work in the interdisciplinary manner? So what we require actually, what why do we study physiotherapy? We actually need to work on the patients also. So after all, the clinicians work to reduce the effects of impairments on the activity limitations and the participation restrictions. But nowadays, all the practices are backed by high quality research, that is the evidence based research. Now why I'm talking about interdisciplinary research? Because it involves drawing appropriately from several discipline or the separate branches of the learning or fields of expertise to redefine the problems, or to find the solutions of those problems out of the box and reach to solutions with a common interest and with a new understanding of complex situations. Now, I would like to give an example of the interdisciplinary research is for myofascial pain syndrome, which is one of the many issues affecting the musculoskeletal system and characterized by the presence of active trigger points, having which is characterized by pain, stiffness, spasm with a prevalence rate of 85%. And these are considered to be as hyper irritable contraction notes also. These actually may be active, latent, central, satellite, and work on a pattern of referred pain, and mainly present in the center of the belly. And these may become active due to any kind of trauma, injury, overuse, and a postural imbalance. Now, what actually causes the development of these trigger points? So, using some body parts in the same way, carrying on or the lifting of the weights in a wrong manner due to sedentary lifestyle, and using poorly designed furnitures with less ergonomical manufacturing, tensing or clenching of the muscles due to mental or the emotional stresses, and even with the prolonged bed rest or inactivity. Yes, certain researchers have also reported that due to deficiency of certain vitamins and minerals, also produce the development of these trigger points, including insomnia also. So now let us understand what is this myophasia. It is the combination of two Latin words. The myo means muscle and the fascia, it is a very tough, thick connective tissue which is covering the which is a covering sheath and surrounding the muscle here in this case, and extends from head to toe. Now let us understand the basic nature or basic physiology of the trigger point, and for this I would like to show a video here. Is my video visible?
Yes, Shilpa, it is visible.
Okay, okay, okay. So, when a sarcomere and any end plate become overactive for a number of different reasons, and one of the reason is the release of the acetylcholine. Also, there starts pathological changes at the cellular level itself, and this turns on permanently the sarcomeres, leading to a local inflammatory response, loss of oxygen supply, nutrition supply, and endogenous involuntary shortening of the muscle is there. And as you can see here, the fiber part elongates, and this stretched part is known as the taut band, and which further increases the metabolic demands of the tissues. And stretched segments of the fiber also give rise to the tension in the taut band, and further subsequently, there is increased in the movement or the number of these trigger points, and further give rise to the tightness in the muscle and the increase in the referred pain pattern depending upon the presence of the trigger point. Now, every time we talk about a theory or the hypothesis that there may be loss of oxygen supply at the microscopic level, that's why there is formation or development of these trigger points. But when a biopsy of such trigger point was done with high resolution respirometry, there was no qualitative difference was found in the mitochondrial function, and no alteration was found in the mitochondrial function having a role in the development of such trigger points, and this is actually reported by certain researchers. Now, these can easily be examined by the Travel and Simons criteria, but yes, actually, if we want to quantify them, we really need very highly costly and sophisticated hospital or certain such settings also, like ultrasonography, such high-end EMG equipments, along with the magnetic resonance elastography also. So this is the best way to examine a trigger point and the taut bands. So going down the history lane, in 1930, Dr. Lange used the sclerometer that proved that the tender areas in the muscles are 50% harder than the surrounding areas. In 1940, Travel developed injection therapy for the treatment of the trigger points, and Travel and Simons both used saline and procaine for the injection and called them the wet needling. Then Travel mapped all the trigger points and the manner in which they radiate to the rest of the body. And then her work really came into existence when she treated the president of their country. In 1976, an exercise therapist found that using knuckles and elbow with sustained pressure gives good results in resolving trigger points rather than the injection therapy. Medical management which is available so far: NSAIDs, analgesics, muscle relaxants, anticonvulsants, antidepressants, Botox injections, etc. And there are n number of physiotherapy treatment also available, but ischemic compression therapy has proven to be very good for resolving such trigger points, but for a good number of sessions to be backed by the patient. Now, clinicians also opt for dry needling for resolving these trigger points. What it actually does, it uh, immediately contracts with a strong contraction of trigger point is there, followed by the relaxation. It alters the muscle fiber length as well as having an inhibitory effect on the antagonistic muscle. It exaggerate the alpha fibers and shut down the A delta fibers and shut down the C fibers and gives the immediate relief from the pain. Then in 1942, Janet Trevell published all the methods of injection therapy into these trigger points, and it was concluded actually by Dr. Lewitt that effect of the drug was coming at its own time, but the relief in the pain was coming because of the mechanical stimulation from the needle itself or the needle alone. So after that, in 1989, Maryland became the first jurisdiction to allow intramuscular therapy, and then they started dry needling. Yes, it is a invasive procedure, but yet very effective. Now, when needle EMG was performed on this trigger point, very high frequency crest and troughs were found. As you can see in the picture also, what it does, very great frequency crest and trough are produced. So, when actual recording of the fiber response after the dry needling was done, there was a sudden contraction followed by the relaxation after the dry needling. So, it was the brain baby of my mentor that what you actually do with your physical therapy or with your dry needling, you people are doing just initially you people stimulate those trigger points, and thereafter the relaxation occurs. So he also gave me an idea. There is a age old drug which is known as succinylcholine, and which is only used by the anesthetist only while intubation, which also works in the same line. It actually works for sudden contraction followed by a good relaxation. So then we decided, why not to have a succinylcholine to be a one of the management for the resolution of this trigger point. Then we did so much survey from the literature, and we found out so many things, but not a single study was reported with that succinylcholine is available other than the injections only. Then immediately we filed a patent, and luckily, fortunately, the patent was published in year 2021 also for a novel application of this succinylcholine drug, which can be used by the physiotherapists only who are having good information and good knowledge of trigger points, to be used as transdermal application only. So this gel was prepared in the pharmaceutics lab of this university, and all the physicochemical properties were checked using two gel bases, that is the carbopol 934 and the 940. This is the only and the actual that gel which is used for the ultrasound therapy. So, six topical formulations of succinylcholine drug along with those carbopol 934 and 940 were prepared. And after all the physicochemical properties, it was found carbopol 934 exhibited the better quality, and formulation second was selected for further in vitro studies. And before that, we took all the ethical approvals from the university. Then while doing all the in vitro permeability studies, all the skin itching studies were also performed, and it was found to be very having very good permeation of this drug through the skin. Then after when we got all the results related to the skin itching, that no skin itching, rashes or other side effects on the skin were found, and good permeation studies were reported with these in vitro studies, then we decided to go for initial pilot study. and only 35 subjects were identified for the study, and only 29 subjects could complete the study. And here what we did, we just applied the 1 gram of the gel, that is 25% of the succinylcholine gel on the trigger point, followed by the ultrasound therapy. That is, physiotherapy was also to be included, because I'm a physiotherapist and it is my first and foremost duty not to forget my profession. So then we did the phonopheresis of this gel on 29 subjects, and here I am talking about only one pilot study, and for only parameter, that is the pain, was recorded on VAS. So all the VAS score uh, prior to the study was recorded, and after 15 minutes, 30 minutes, 2 hours, second day and third day, all the VAS score again for pain was recorded. And you won't believe that all the results, even after 15 minutes, 30 minutes, 2 hours, second day, third day, none of the pain, none of the patient reported that they have gone through all that, the same pain that they were having before the therapy. Right from the 5 minutes itself, patients started reporting that our. So it can be concluded that the phonophoresis with succinylcholine, if applied on the trigger point and if used wisely by the physiotherapist only, is very effective in reducing pain developed by the myofascial trigger points, and ultimately in reducing myofascial pain syndrome also. I have completed a great and good, big project with this gel only, on several other parameters and a statistically calculated number of subjects also. Now, what are the barriers actually which are resisting us from doing such kind of research? Because there is a lack of time in academia. Because of that NAC work, ISO, so many accreditations, we are not able to even teach properly. So there is a really lack of time in academia as well as for the clinical setup to conduct such kind of studies. Next is the fear of research thefts, and really scientific misconducts happen during the research. Now, I would like to say, let us all promote interdisciplinary research in physiotherapy profession with all good research skills, critical thinking, good collaborations, good program exchange, inter-university program exchange. Everything can be done by the physiotherapists also. So these are the references. Thank you so much.
थैंक यू सो मच डॉक्टर शिल्पा। ये बहुत अच्छा टॉपिक था जो हम पढ़ाने के टाइम पे भी ये बहुत ज़रूरी है एमएफआर के बारे में, और बहुत अच्छा टॉपिक था ये। और ये बात सही है कि एकेडमिक सेटअप के अंदर पढ़ाने के लिए और रिसर्च के लिए टाइम थोड़ा कम मिलता है बिकॉज ऑफ दी गवर्नमेंट की जो चीज़ें हैं, नैक और वो सब चीज़ें। लेकिन बट इट वाज रियली गुड प्रेजेंटेशन। और वो तो मुझे पता है कि अब आई एम योर प्राउड सीनियर, तो मुझे बहुत प्राउड होता है कि जब जूनियर्स इतना अच्छा करते हैं और इतनी अच्छी सी पोस्ट पे जाते हैं तो प्राउड फील होता है। और कैसे ही 20 साल बीत गए पता ही नहीं चला। बट थैंक यू सो मच, और स्टिल अपने बिजी शेड्यूल से थोड़ा टाइम निकाला मेरे लिए, एंड थैंक यू सो मच।
Thank you, sir. Thank you so much, sir. Thanks a lot. Thank you, everyone.
Dr. Nancy, over to you for the further proceeding.
Thank you, ma'am, for your wonderful session. Now we are just with one paper presentation. I will call upon Kasturi, BSc RT, third year.
Namaste to all of you. Namaste to all of you. Today I, Kasturi, from Faculty of Physiotherapy and Diagnostic, pursuing BSCRT third year, is here to present my presentation on the topic Recent Advancement in Treatment of Cancer. So here the introduction. Prostate cancer is a development of cancer in the prostate, a gland in the male reproductive system. The prostate is a walnut-sized gland located in front of the rectum and below the bladder. This is the tube that carries urine out of the body. The cancer cells may spread from the prostate to the other areas of the body, particularly the bones and the lymph nodes. The majority of cases, more than 75%, occurs in men over age 65. It is the sixth leading cause of cancer death in men. It is a malignant tumor of the prostate gland. Proceeding, what is the causes that it causes prostate cancer? Well, it's not clear that what causes prostate cancer. When some cells in your prostate becomes abnormal, then prostate cancer begins. Then it mutates in the abnormal cells and causes to grow and divide rapidly than normal cells do. And these abnormal cells continue living, and then other normal cells die. Then the other normal cells die, and then they accumulate and forms tumor and then grow and invade the surrounding areas, and it affects the almost surrounding tissues. Then some abnormal cells can break off and spread. That's metastasize to other parts of the body. Symptoms of prostate cancers are there like painful or burning urination, feeling that your bladder has not emptied fully, needing to pee more frequently, often during the night, a decrease in the amount of fluid ejaculated, a slow or weak urinary system, blood in the urine or semen, bone and back pain, pain in testicles, weakness or numbness in the legs or feet, loss of bladder or bowel control, weight loss or loss of appetite. Risk factors. Older age, it increases with age, and it's most common in men older than 65. Being black. Black men have a greater risk of prostate cancer than do men in other races. It's also more likely to be aggressive or advanced. Family history of prostate cancer. If men in a family have had prostate cancer, your risk may be increased. Obesity. Obese men diagnosed with prostate cancer may be more likely to have advanced disease that's more difficult to treat. Infections. Infections that are caused by prostate cancers. Infections with chlamydia, gonorrhea, or syphilis seems to increase the risk of developing prostate cancer. Chlamydia, gonorrhea, or syphilis is the sexually transmitted infections. Uh, Other is human papillomavirus (HPV) has been proposed to have a role in prostate cancer incidence, but the evidence is inconclusive. Human papillomavirus is also a sexually transmitted infection, and there are more than 100 types of human papillomavirus in humans. Treatment for prostate cancer is like active surveillance. Active surveillance, you should be for regular checkup. And in prostate cancer surgery, prostate part of the men should be removed or can be replaced. In radiation therapy for prostate cancer, radiations are given to treat them. And in prostate cancer hormone therapy, hormones like testosterone is given so that possible of risk of prostate is suppressed. Chemotherapy for prostate cancer, high doses of drugs are given. Immunotherapy for prostate cancer, in this own immune is given to suppress the prostate cancer. Prevention. It is not known yet how to prevent prostate cancer, but here are the some keys like not smoking, healthy diet, physical activity, healthy weight, and all these factors also help to lower the risk of many types of cancer, risk of heart disease and stroke. Thank you. Thank you, Kasturi. Now, I like to call faculty members of physiotherapy and diagnostic. First of all, for first presentation, I like to call Dr. Ransi Koshi.
Uh, Thank you. Namaste. I'm JV Dr. Rensi Koshi. Today I'm going to present on the topic role of telehealth in pregnancy. Let me share my screen. Greetings to all. Uh, as we know that we are attending the international conference on emerging trends in pharmacotherapy and health technology, and my title is role of telerehabilitation in pregnancy. Pregnancy, it is an important phase in woman's life which needs to be given proper care. Pregnancy is a period that comes in every woman's life, and that has to be taken very proper care, because there are three different types of trimesters in which different changes occurs in the body. That is, changes occurs like such as hormonal changes, physical changes, and also our psychological changes occurs too. For these all changes, special care is needed to be taken care. And these today's my topic is telerehabilitation. Telerehabilitation, it is a remote provision of rehabilitation services that uses information and communication technology. Telerehabilitation is a form of rehabilitation itself, but it's in a, virtual mode, so that patient who is not able to visit the physiotherapy clinics regularly on a regular basis, they can consult their physiotherapy doctors through their phones, or through any form of their virtual modes. And according to World Confederation for Physical Therapy, telerehabilitation is said to be that as it improves the accessibility to care and offers a physical therapist an opportunity to deliver care in accordance with a new model of delivery. Role of telerehabilitation. As we can see, there's three different blocks. The first is telephone and pre-recorded video materials. These telerehabilitation technique, which initially started with telephonic conversation, that also included pre-recorded video materials that was shared with the patients and their family members, so that they can these materials can help them self assess themselves, so that they can give a proper diagnosis, as well as a proper management of the conditions can be done. Next is live video conferencing, web-based interactive software, text messaging technology, sensor-based technology, virtual reality platforms. These techniques are the recent techniques where the patient can interface or contact with their physiotherapist directly through their video conferencings, or they can interact with their doctors, like they are contacting as a face-to-face interfaces itself. Next is a smartphone and application. These smartphone applications are very helpful these days, as we all are like many of us use smartphones and like smart watches, which helps in assessing or assessing and evaluating your vital signs while performing any aerobic exercises or any exercises during the pregnancy period. As we all know that pregnancy, heart rate, blood pressure, respiratory rate, they all fluctuate by the trimester periods. While performing exercises, these wearable devices help in regular monitoring of the patients. Other role of tele rehabilitation is that it benefits the gap between specialists and clients. Like they are like females who are not able to access the physiotherapy clinics regularly, or they are not or in females that they don't have access to physiotherapy clinics in their areas. These clients can easily contact and connect with their physiotherapy through smartphones, and these telerehabilitation saves time because you don't have to go visit, and like you can save your traveling time and waiting time in the clinics. Other like minimizes direct and indirect expenses, because as we visit any physiotherapy clinics, there different section charges are there, but in video or like telerehabilitation sessions, their consultation charges and other charges are minimized a little, and therapists and clients personal one-to-one connection is there, so our doctor can clearly and focus on one patient. In through telerehabilitation, it's not only one patient per doctor, but yes, a group therapy can also be performed. And wearing wearable devices, regular monitoring can be done of vital signs. This telerehabilitation promotes clients' active participation because they are present in their natural play environment. They are comfortable with that rooms and that temperature, and they are comfortable in their place itself. And it also protects from any type of infection during this pregnancy period, because this period is prone for infections also. Significance of physiotherapy in pregnancy, like physiotherapy is very necessary in a pregnancy period. It decreases cesarean operations, it helps in vaginal deliveries, and also it helps in postpartum recovery. Physiotherapy care for women in labor, because this period is a very crucial time for a female and their doctors as well, because this time period requires careful observations. And because female is undergoing with pain, and it during this physiotherapy sessions, females can overcome pain, and they can focus on the uterine contractions easy to deliver a baby easily. Otherwise, prevention of postpartum depression. It helps in the prevention of excessive gestational weight gain, because regular exercises is going through. The females will not increase their weight, because obesity and incorrect posture can lead to postpartum pains, lower back pains, and other pains in the females too. It reduces the risk of obesity in pregnancy, and it reduces pregnancy complication as well. Telephysiotherapy in pregnancy, telerehabilitation in pregnancy, that helps. These type of methods or management techniques can be done, like we can introduce with to the female clients during their pregnancy period, like poster training to correct to focus on the correct biomechanical corrections, to do not to forward bend and to sit straight. Other posture corrections can be done through telephysiotherapy, and this telephysiotherapy can work in reducing pain, because as the abdominal distension occurs, the lordosis and lumbar spine increases, that increases the lumbar spine, lower back pain. So telephysiotherapy can work in reduction in pain, breathing exercises, because as the abdominal distensions takes place, diaphragm is compromised a little, and so breathing difficulty takes place. We can teach breathing exercises to the females during their antenatal care programs. These breathing exercises can help during pregnancy and during labor also. Relaxation methods, muscle strengthening, because during this time period, ligament laxity takes place and women are like more prone for a weaker area. So these time period helps the muscles to strengthen, so that after delivery of a baby, after a childbirth, females can their recovery period can be like little faster. Pelvic floor rehabilitation, childbirth education, and preparation of labor and delivery, these all the techniques, these all the management techniques can be through tele rehabilitation. Women can the women's help, they get to connect with their therapist, and regular monitoring, regular consultation can be done, and regular education can be done to the females, so that they can have a better and happier pregnancy period. Benefits of telerehabilitation: it is cost effective, it is easily, it is approachable, it maintains physical function, because we are performing different exercises, so it helps in physical functions. A smart technology like wearable devices helps to monitor the vital signs, saves traveling time. Home-based exercise training like aerobic exercise trainings, and we have seen different types of techniques, and these all help in improves the well-being, thus improves the quality of life in females. Telerehabilitation also have some limitations, like physiotherapy has hands-on approach techniques like spinal manipulations and like myofascial release techniques, and different hands-on approach techniques which cannot be performed through this virtual mode, and other is non-accessible to non-techno-friendly people, because who are not not aware, or like not using their smartphones, or like not able to they are not techno friendly. These people are not like able to have telerehabilitation. Availability of assessment treatment tools that replicating face-to-face practices that are lacking here. Give some of the assessments and treatment tools like electrotherapy treatments, these cannot be given through a telerehabilitation force. These are my references of these my study. Thank you. Uh,
Rancy, we will
yes.
take Dr. Rajni presentation first, and then we'll continue with the others. I warm welcome Dr. Rajni, and thank you so much for accepting our invitation. And she's a senior faculty in SMS Medical College, and thank you so much for your time, ma'am. And over to you. Thank you.
Thank you so much for inviting me. So, a very good afternoon to all of you. I am Dr. Rajni. I am medical physicist and assistant professor, along with a radiation safety expert in the Department of Radiological Physics, SMS Medical College. I serve as a radiation safety expert to Government of Rajasthan as well. I'm very happy to be with you all today, as today I just want to talk about the application of radiation, which is like you can name it and radiation is there. So I'm from radiation background, so I'll be talking moreover about like applications of radiation in various fields. So if you talk about the uses, it's numerous. Like whether you talk about industry, whether you talk about medicine, whether you talk about academics, whether you talk about research, radiation is everywhere. So as Madame Curie has rightly said, there is nothing to be feared, it only has to be understood. It means radiation is something, whenever you say radiation, or common people will have a fear in their hearts, or radiation is something means bad. But I'm telling you, radiation has more good than bad. And it's about the publicity that we always do in a bad terms, not in a good terms. So today I'm here to focus more about the application of radiation in medicine, and I will tell you what wonders radiation can do. So if you talk about radiation, application of a radiation, particularly in medicine, we can classify it in three departments basically:
radiation diagnosis, or you can call it radio diagnosis, or nuclear medicine, or radiation therapy. So if you talk about, we'll take them first one by one. So it's not about just three department, whether you talk about cardiology, whether you talk about any operation theaters, you will see the CR machine, you will see the radiation equipment which are being used. There are wards where you will have this portable x-ray machines. So in hospital nowadays you can see radiation everywhere, but basically all these facilities are governed by three main departments. So we'll take one by one. So let's talk about radiation diagnosis department, or radiotherapy, radiology department. So radiology department is all about like doing kind of diagnosis, which may be from various tests. Like nowadays we used to see like CT scans, normal X-rays, mammography, you name it, and it is there. So there was a time, at the time you first cut the body and then you see what is the problem. But now the era has changed, the things are revolutionized. Now you first see and then you cut open the body. So since the discovery of x-ray, since the discovery of radioactivity and the x-ray by German physicist WC Röntgen, the medical radiation diagnosis, or radio diagnosis is revolutionized. So now everything is like radiation is used for betterment. As you all know, all the experiments are done on the brave women. So the first X-ray available to the humankind was with from the wife of WC Röntgen, as he has experimented his discovery on his wife itself. So now if you see radiation diagnosis department, now for everything like small injuries, very small injuries, even smaller to very larger injuries, any compression in the bone, anything like that, we'll strictly go for x-ray, go for CT scan. So x-rays, where we call it x-ray, so it is basically an x-ray. We take an x-ray radiography, so it is 2D radiography. When you do CT radiography, then it is three-dimensional x-ray radiography, which is called as CT. It has numerous application. So now this is the part of this is the part of advantage with what we have from radiations. So now we don't have to worry about fatal injuries and things, like we have to open the body and then we see, okay, what is the problem. Now we have to go a painless procedure, just a CT scan or an x-ray, and you are good to go. Like is there any kind of fracture, is there any kind of blood clotting, or and this cause nothing, like it's not a kind of any traumatic experience on the patient. So definitely the field of radio diagnosis has revolutionized the medical services what we provide to mankind. Now let's come to the second department. So now the second department is nuclear medicine department. So you can classify this department in the two parts. The 80% of part is of diagnosis and 20% part is mostly treatment. So diagnosis, have you ever heard about this PET CT? Okay, so let me give you a very simple overview of nuclear medicine department. In this department, we used low activity, means low energy, low activity, unsealed sources. Means radioactive sources are used with a pharmaceutical. They are attached with the pharmaceuticals, and particular body part or target or a site is targeted to analyze the metabolism, metabolic activities, radiation biology of that kind of site. So PET is a such kind of a test in which you give FDG, a kind of a radio isotope. I don't want to go for such a technical terms too much. I just want it to be make it quite easy to understand. So we attach a radio pharmaceutical. We attach a radioisotope to a pharmaceutical which can target a particular body site. When you give to the patient, and we have a machines called gamma camera or even a PET CT, you can take their PET CT, and then we analyze the physiological culture of that disease, or we can study the metabolic activity of that disease. So now there are various tests which can be done as a marker test. So now nuclear medicine has evolved quite much. There was a time like 10 years back, nuclear medicine was not that developed, but now it's quite developed, and now it's routinely used for cancer patients. And if you talk about the therapeutic part, so basically like sometimes we have thyroid disorders, hyperthyroidism, hypothyroidism. In that kind of cases, nuclear medicine can give the treatment by having the iodine therapy, radioactive iodine therapies. So yes, this is also a department which governs or which kind of use radiation very extensively. Lastly, I'll talk about the radiotherapy department. So radiation therapy department is totally therapeutic department, 100%. Here we are giving treatment to the patients. So basically in radiation therapy department, we use radiation in the form of high energy seal sources or medical accelerators to provide radiation to cancer patients. This can be done in a various formations, like it can be given from a distance, which is known as a teletherapy, where there is a distance of like 1 meter between the patient and the radiation, or you can radiation producing equipment. So in this category, you can have a actual radioactive source with a machine, which you call telecobalt machines. You can have a linear accelerator as well. In linear accelerator, we used to produce X-ray machines. X-ray is a kind of also radiation, but the X-ray in the radiation therapy department and in the diagnosis department has lots of difference. It means they have a difference of 1,000 times in comparison to your diagnosis department. So what you are using in diagnosis department, it will be increased by 1,000 times, and then we given to the cancer patients to kill the tumor cells. So now there is also a type we called brachytherapy, in which we used to put the sealed sources inside the patient body for cure of the tumor. So there are various types and forms. Sometimes the radiation is used as a pallet, sometimes it is used as a miniature sources to the human body. So now radiation has lots of application in the field of medicine. And now there are various other uses also which is coming up, like genetic information, genetic studies, or marking test, and many more. So at this platform, I just want to inform all the young students, young ladies, that we have to, like what Madam Curie has rightly said, nothing to be feared, it has to be understood. To feel encouraged about this field, radiation field is a good field, and it's a challenging and demanding field. It required good professionals. So you can safely, without any worries, without any, kind of a backlog in your mind about the bad things about radiation, you can always use radiation in a very good way, in a very positive way, and make an impact on the humankind. So at the last, I just want to say, be encouraged, and if you are willing, you can visit our department also, if you want to see with your real eyes, like how it is used and how it is worked. So I'm happy to be with you, and I'm really happy to inform you about that, and I will be very happy if you give a chance to this kind of a field, to pursue this kind of a field. So thank you very much for inviting me and giving me opportunity to share my views with you. Thank you so much.
Thank, thank you, Dr. Rajni, and thank you so much for your time. And it's really indeed a knowledgeable session. Thank you so much.
It's a pleasure.
So we are proceeding with our last eminent speaker of the day, Dr. Stephen. He is a CEO of Syriax Institute, Belgium. And thank you, Stephen, for accepting my invitation on a very short notice. And over to you. Thank you so much for your time.
It's my pleasure. So it's also a surprise for me. Well, we met each other some time ago when you followed my mastermind training program in orthopedic medicine in Belgium. So we had a very, very nice time together. The purpose of this session is, well, as you know, I'm responsible for the Global Celiac Institute, and I, together with my team, I offer courses in modern orthopedic medicine all over the world. We also have a series of online courses and other options. And the purpose of this session is that I don't know how many people are online at this moment, but it's going to be a Q&A session. So if you have any questions related to orthopedic medicine, related to clinical reasoning, diagnosis, treatment strategy, whatever, well, then now is the time that you ask your question. And if I can help you, it's going to be my pleasure. So I'm ready for the first questions. So who is going to share the first challenge with me? Surprise, surprise.
Stephen, I would request you because they are all our bachelor students and they are not much exposed to celiacs. And once I completed, when I came back from Belgium, I only introduced them with the celiacs and told them about the benefits of celiacs. So I request you please give some enlightenment on celiacs method so that they will get to know about.
Yeah, okay, no problem. Well, what is celiacs all about? It's not about friction massage and a specific manipulation, because many people still believe that celiacs is old-fashioned, just a stupid friction massage. Actually not. Celiacs is something totally different. If you're interested in musculoskeletal medicine, orthopedic medicine, then the clinical reasoning system we teach is something you absolutely need. We all know that in our profession, in the musculoskeletal profession, there are so many different methods, so many different ways to examine a patient, so many different treatment options. But the reality is that many of those options are just an illusion, are just, and I'm going to be very undiplomatic now, are just complete, total nonsense. And that's something we have to realize. There are many procedures in the manual therapy world which don't have any relevance whatsoever. One example, for instance, is manipulation of sacroiliac joint. Well, this is just an illusion. There is zero, but really zero scientific backup for that. Now, that's something we have to realize, and that's something we like to counter in an orthopedic medicine course. So, what is celiacs about? Well, it's about diagnosis, diagnosis, diagnosis. Imagine your patient, shoulder patient. The patient comes to you and says, "Oh, my shoulder hurts." Okay, what's the problem? What happens too often in many physio clinics is that within 30 seconds, the patient lies on a treatment table, and then therapists are doing some ultrasound, electrotherapy, immobilization, whatever. We just do something. But when I ask to the people, what are you doing? Why are you doing that? What's the diagnosis? Well, then, unfortunately, in many cases, I receive a non-answer. So the first thing you do with this patient here, first you're going to do a very good history taking. You're going to ask the questions that need to be questioned. And based on the history taking, then you're going to find out if this problem is a real shoulder problem or if this problem is perhaps referred pain from the cervical spine. Perhaps. Then you use your eyes. After using your ears, you use your eyes. What do you see? Are there elements in the inspection which are relevant or non-relevant? We also don't have to exaggerate with elements from the inspection because this is also a specialty of musculoskeletal therapists. We all see things that in fact don't really matter. Oh, the scapula is positioned a little bit in this position, a little bit in that. Oh, there is a discrepancy. Let's not exaggerate with those things. Most of those findings are symptomatically irrelevant. So we did the history. We had a look at the inspection, and then we're going to do a functional examination, and we're going to try to perform relevant tests. It doesn't make sense to kill your patient with tests. If you look in the manual therapy world, in, for instance, examining a lumbar spine patient, you can find at least 90 different tests. And you can feel this and you can feel that. Most of those things just belong in the David Copperfield department. Magical department. Yeah? Most of those things are completely irrelevant. So we're going to focus on a relevant functional examination where we test each structure separately, if possible, or each group of structures. And once we did an examination, then we have to interpret the pattern. What did we see? Yeah, which pattern did we see? Something we know, something we don't know, something we expect, something we don't expect. Are there red flags, yes or no? So we have to analyze the pattern we saw. And this is, of course, the most difficult element in clinical reasoning. And then the question is, this pain, if it is a shoulder, where is it coming from? Is it coming from a muscular problem? Is it coming from a ligamentous problem? Is it coming from a capsular problem? Is it a bursitis? Well, your clinical image is going to show in which direction we are thinking. And if it is a muscular problem, okay. Is it more supraspinatus, infraspinatus, subscapularis, biceps? Where exactly? So sometimes we really can reach a more specific diagnosis, and this is very interesting when you think of your treatment strategy, because besides of the general exercise therapy you do, you can also do some more specific treatments. For instance, on the tenoperiosteal aspect of the supraspinatus. So for me, Syriax is all about objective clinical reasoning. And we also have to realize that there is a huge difference in the clinical reasoning process between lesions of the extremities and lesions of the spine. Yeah, there are many different, I told you, there are many different methods in our world. And sometimes I get the impression that some methods want to be the all-inclusive method. You use the same strategy, you see the same techniques for the extremities, the spine. And unfortunately, I disagree, because the biomechanics of the extremities and the spine is totally different. So for those two regions, you cannot also use the same clinical reasoning strategy, the same kind of testing. Yeah. In the extremities, we often reach a specific diagnosis. In the spine, we practically never reach a specific diagnosis. It's more an unspecific diagnosis. But in a nutshell, this is orthopedic medicine. Clinical reasoning, diagnosis. And then you determine, okay, what are we going to do with that patient? Is every patient a patient for the physio? No. Some patients are very suitable for the physio, where we do some exercise therapy, perhaps some friction massage, manipulation, mobilization, preventive strategy. But some people are not for the physio. Some people need help from a doctor. Some people need some kind of infiltration or injection technique. There's some pathologies which react super good on injection. For instance, an acute bursitis in the shoulder. The physio can't do anything very efficient with that. One to the point infiltration, and the patient is immediately much better. So that's orthopedic medicine. Do you have any more questions about that?
Thank you so much, Stephen, and for your time. And it's really a knowledgeable session. And hopefully, I'm also introducing in future about Syriac certifications and to the university. And hopefully, we'll go for a MOU with the Syriac Institute soon. And thank you so much.
It's my pleasure. So, for those of you who are interested, you just surf to celiax.eu and you can download a lot of free materials. I have a free ebooks for you, free assessment forms, some free videos. Just log in on celiax.eu and then you're going to receive some emails with me with a lot of free downloads. Okay?
Thank you so much, Stephen.
Okay, so I wish you all the best. Thank you for the invitation. Enjoy your day. And I'm going to continue with my next patient now. Okay?
Thank you so much.
Thank you. Sure.
Bye bye.
Thank you. Bye bye.
Over to you, Rancy.
Thank you.
Thank you so much, sir, for you enriching session on celiac. Okay, next I call upon Dr. Triveni Kurana for the next presentation.
Namaste everyone. Myself Reni Kurana. I am here to present my scientific paper presentation entitled Physical Therapy Overcome the Major Community Health Issues Related to Movement and Health, which is under the Basket International Conferences 2023, which is organized and sponsored by the Jyoti Vidyapeeth Women's University, Jaipur. And today it is the second day of the International Conference on Emerging Trends in Pharmacotherapy and Healthcare Technology under the session of Emerging Physiotherapeutic Technologies in Health. Let's see about my study. What is physiotherapy? Physiotherapy is a healthcare profession that assess, diagnose, and treat to prevent many diseases and disabilities of various ranging from the pediatric population up to geriatric conditions, and that is not limited to women's health. Of course, women's health is a special interest of physiotherapists nowadays. Now, let's see what about the community health. Community health is a medical practice which focuses on people's well-being in a particular geographical area. So, now I am addressing the specific health issues: the back pain, neck pain, stroke, obesity, migraine, breathing difficulties, road traffic accidents, and particularly fall in our geriatric population. They restrict movement that impact our overall health, found major common community health issue in the population of underserved individuals, in particular young people, low and middle income, and established group of community. The whole community is suffering from backache, neck pain, stroke, obesity, migraine, breathing difficulties, falls, RTA. Now, what is the aim of my study? It is to help foster improve science of prevention, that is the community health, and practice throughout the cycle of care from initial evaluation to discharge. During my study, I found the new prevention, that is the quaternary prevention, which is focused on the preventing harm from medical interventions. Previously, as we know, the prevention is better than cure. So prevention makes up a large part of treatment. Under the prevention, we have four types of prevention: the primordial prevention, which focus on reducing risk factor; the primary prevention, which aims to prevent the diseases; the secondary prevention, which focus on early diagnosis; and the tertiary prevention, that focus on reducing the symptoms of disease once the disease has progressed. So, under the tertiary prevention, the physiotherapist comes their role. When it comes to literature review, Binder and Crofter et al. Said neck pain affects most adults at some point in their lives, and nearly 20% of population suffers from persistent and recurrent symptoms. Fala et al. In 2004 said individuals with neck pain may have deficit in the coordination activities. As per O'Leary, strength and endurance is also affected in the neck pain patients. Crystal Jason reported repositioning acuity deficiency in the neck pain patients. Michelle has established in their papers that the postural stability is very affected when the patient is suffer from neck pain. And as well, oculomotor control documented by Trellin et al. In 2005. And patients with the neck pain may also have mobility deficit in cervical and especially in the upper thoracic region, said by Childs et al. In 2008. When the migraine, uh, let's see about the migraine literature review. As per the Lipton, Stewart, and Moncrief in 1997, they document the prevalence of migraine 70 to 90 per thousand of population, and that accounts overall 80% of from loss via daily works. Now, stroke is a clinically defined syndrome involving the rapid development of symptoms or signs of focal loss of cerebral function with no apparent cause other than those of vascular origin, said by Warlow in 1998. And the loss of functions caused by stroke can be global. As per prevalence, the rate rises steeply with increasing age, and for people aged 45 to 85, is approximately 4 per thousand of population annually reported. Let's say about the literature review of the low back pain. As per Duscher et al. In 2014, low back pain classified according to the pathoanatomic and socio-psychological criteria. Epidemiological data indicates that a chronic, widespread, non-specific musculoskeletal pain is on the rise, which may result in significant challenge to healthcare providers and that add to ever-increasing cost of our healthcare, especially in the area of chronic low back pain. This is documented by the Wolf and Elzak in 2005. My methodology during my study, the searches were conducted in databases including Cochrane Library, NCBI Library, Medline, and Base, internet searches of Google and Google Scholar, related textbooks, reference books, various newsletters, various hospital annual reports were part of my study. And the databases were reviewed without time limit until April 2022 with the inclusion criteria, the epidemiology of neck pain, back pain, stroke, fall, road traffic accident, and obesity. Now, the discussion. Though the management of community health is a complex process, as we know, it is achieved through a multidisciplinary approach by doctors, nurses, psychologists, physical therapists, occupational therapists, dietitian, and social worker. Perhaps newly adopted whole body electromyostimulation intervention demonstrated improvement in functional capacity. Another emerging technique in the field of physiotherapy, evidence of the kinesthetic retraining, shockwave therapy, integration of ergonomics, and robotic research is rapidly changing the scope and limitation of our physiotherapy practice over traditional physiotherapeutic approach, that is strengthening, stretching, and other manual techniques used for various disorders that found effective to manage the persistent pain. Other than these, next emerging technology we have video games named Nintendo Villi. This is the particular technique used in our paralytic cases, especially to improve our dexterity, mobilization, manipulative skills. Other than these, rehabilitation robots, Ascono Bionic Suit. This Asco Bionic Suit is also for the rehabilitation tool for mobility or gait training in the case of hemiplegia. These shown as a breakthrough technology to regain movement. Now, what is the limitation of my study? As therapist needs to turn well-structured randomized clinical trials to determine to need to these adopted technologies. Future scope related to my study, many of these interventions are safe and feasible for most clinical settings. The data presented in my paper might consider as extending current knowledge on the physiotherapeutic approach, regaining functional movements. So now I conclude that the comprehensive physiotherapy, including inculcation of robotics, shockwave therapy, functional movement training, ergonomic control, corrective exercises, along with corrective body mechanics, Also, the breathing retraining need to focus when the one of the following deficient, whether it is in the acute state or locomotor state. So we have to manage our locomotor strategy in the patients, non-locomotor strategies in the patients, and dexterity, especially in the neurological cases. So I conclude that the physiotherapy not only reduces morbidity rate of patients, but also accountable transforming communities, overall improving patients' quality of life. Here are references I go through. Thank you.
Thank you, Trivedi ma'am. Next, I call upon Surbhi Chaudhary for the presentation.
Namaste. I, JVN Survi Chaudhary, lecturer of physiotherapy and diagnosis, Department of Radiation Technology. I am presenting my topic, treatment techniques of breast cancer. In this, we have to discuss what is breast cancer. Breast cancer is a disease in which cells of breast grow out of control. It is most common cancer in women worldwide, although occur in men, but in less frequency. Breast cancer typically begins in the milk duct lobules of breast and can spread to other part of body. Here we discuss the anatomy of breast. Breast is supported by chest muscle, that is pectoralis, and this is the milk producing gland, pear shaped, 15 to 20 lobes arranged in circular pattern. Each lobe is comprised of many lobules, at the end of which there are tiny like glands or sacs where milk is produced in response to the hormonal signal. Areola is a darker pigmented area around the nipple. What are the causes of breast cancer? There may be hormonal factors, genetic factor, age-relating factors, sex, smoking, alcohol, and radiation exposure. What are the signs and symptoms? साइन हम देख सकते हैं a change in size or shape of the breast, a change in the size of nipple, crusting, ulcer, redness, inversion, nipple discharge, a change to the skin of your breast, redness or dimpling, a new lump or lumpiness, especially if it's not in one breast, and usual pain in your breast or armpit that does not go away. For imaging of breast, we use mammography. Mammography is a imaging X-ray imaging technique which is used for diagnosis and screening. A radiologist will carefully examine a mammogram to search for high density regions or areas of unusual configuration that look different from the normal tissue. Here we can see that calcification. This is the microcalcification seen in mammogram. These can be related to age or it can be a calcification or a cancer tissue. Early evaluation of 3D mammography suggests an improved detection of breast cancer that's seen with 2D mammography, but extensively large scale comparison of tomosynthesis with 2D mammogram in randomized study are still in progress. And this is a mammographic machine. Um, Risk factors. What are the risk factors that causes for a breast cancer? Starting menopause at a later stage में menopause हो, having no children or having a first child after 30 age, women with previous history of breast cancer, not breast cancer, or breastfeeding, drinking alcohol, using birth control pills, lack of exercise. What are the treatment technique for the treatment of a breast cancer or tumor? We can occupy surgery first, which is called lumpectomy or mastectomy. Then after surgery we have to go for radiation therapy, so that reoccurrence is least, whole breast irradiation or brachytherapy. हम इसमें जैसे टेलीथेरेपी, ब्रैकीथेरेपी दोनों को यूज कर सकते हैं। टेलीथेरेपी में हम होल ब्रेस्ट इरेडिएशन हम इरेडिएट करेंगे होल ब्रेस्ट को, या फिर ब्रैकीथेरेपी छोटे पार्ट को हम ट्रीट करेंगे। ब्रैकीथेरेपी में हम सोर्स यूज करते हैं 2 सेंटीमीटर से छोटा, और टेलीथेरेपी में हम बड़ा सोर्स यूज करते हैं, उसमें हम एक डिस्टेंस लेते हैं। कीमोथेरेपी में हम ये ड्रग्स का यूज कर सकते हैं, जैसे कि डॉक्सीटेक्सेल है, एपीरिबिसिन है। इन ड्रग्स को हार्मोनल थेरेपी दी जाती है, टारगेटेड थेरेपी दी जाती है। कंक्लूजन, now I conclude my topic. The main goal of treatment for breast cancer is to cure cancer patient or prolong their life, considerably ensuring a good quality of life. With the advancement in the treatment for breast cancer, the mortality rate from breast cancer is decreasing. It is also need to be integrated with palliative care program, so that patient with the advanced cancer who can no longer benefit from treatment will get adequate relief from physical, psychological, and spiritual suffering. Thank you so much.
Thank you, Surbi, for this wonderful presentation. At last, every good thing come to an end. So, at last, I invite our president in charge of Jyoti Vidyapeeth Women's University, Professor Dr. Raghav, for the vote of thanks. Please, I also welcome you, sir, for this conference, and thank you so much.
Thank you. Namaste. Good evening, Honorable Chairperson, Ma'am, Mithilesh Garg ji, Honorable Advisor and CEO, Sir Vedant Garg ji, our Registrar, Ma'am Dr. Hema Bafila, Dean and Director of Faculty of Pharmaceutical Science and Faculty of Physiotherapy and Diagnostics, all those who are connected with us virtually on this platform. It is a matter of great pleasure that from last 2 days, this conference and emerging trends in pharmacotherapy and health technology has been, conducted. It went very well yesterday as well as today, 24th and 25th May 2023. And as I am seeing, several deliberations were given and international speakers were added. International presenters were there, students presented the papers, and really there were some good deliberations. Means in today's scenario, we definitely need the latest health technologies. And the interesting thing, yesterday we talked about the drugs, the pharmacology and pharmacy, and today we talked about the physiotherapy. And it was looking like that we are in a global world. There were so many experienced speakers from different countries, and I would definitely like to mention few of them. We were having with us Dr. Sneha Ambavani. She is from Rajasthan herself, and Madam Bama Vivi Menon, she was from Malaysia, and Dr. Stephen was from Nigeria, and Dr. Ashish Wadhwani was from Mauritius, and Dr. K. Norula was from Ethiopia. The list is long. More than speakers from more than 10 countries, they contributed to this international conference, and it was in real meaning the international conference. And now it's time to and one more thing, more than 40 papers were presented during this conference in last 2 days. And it's now time to say thank you. First of all, we are very thankful to our honorable advisor and CEO, Sir Vedant Garg sir, for providing this platform, to our registrar, to the university management, because without their effort, to conduct this international conference was not possible. And thank you very much to all these speakers who spared time for speaking, sitting far away, and time difference was too much. Still they made themselves available, contributed, and talked about this title of about this topic of the conference. And I would like to especially thanks to both. First of all, to my colleague and Dean and Director of Faculty of Pharmaceutical Science, Dr. Dharmendra Ahuja sir. He really did a lot of hard work and brought so many speakers of international level at one platform. And then to the very young and I would say very active, our Dean and Director of Faculty of Pharmaceutical Science, Dr. Ankit Bhargavji, that he also did a lot of hard work in bringing all the speakers on this virtual platform together. It's not an easy task. It takes time, effort, So we are thankful to you, and I would also like to congratulate you, organizing it and conducting it successfully. And students also participated very well in this. So thank you to them also. Thank you to the technical team. Thank you to the and complete organizing team. Thank you to everyone who directly or indirectly participated, helped us in conducting this international conference on emerging trends in pharmacotherapy and health technology, 24-25 May 2023. And at last, thank you for having me. Thank you very much. Jai Hind, Jai Nari Shakti.
Thank you so much, sir. So we conclude this conference with Raghav sir's vote of thanks, and thank you all the delegates who have attended patiently this conference. And thank you so much, sir. Thank you, Dharmendra Ahuja sir, for supporting me so much for this conference. And thank you so much.
Thank you. Thanks a lot.